All right. Good morning. Welcome to Live Office Hours. I am your host, Coach Joshua. So good to be with everybody today. So, we have different audiences today. So, our regular students, hey, everybody, I see you on Zoom. Well, if you will, turn on, some of you don't have your cameras on. I want to be able to see you. Anya, Zach, Brendan, Thomas, how's everybody doing? So, as everybody's coming in, we're going to go ahead and get started right away. So turn on those cameras so that I'll be able to see those smiling faces. For those of you on YouTube or Facebook, I can't see you. So what I want you to do is I still want you to participate. I want you to stay active in the chat. I will try to monitor it. Sometimes it starts going too quickly and I can't keep up, but that's okay. So welcome everybody. Now, let me go ahead and do something first. For those of you in Zoom with me, let me go ahead and drop in the slide deck that I'll be using today. Okay, so that is coming right now. You'll be able to follow along with me. Now, what I want for everybody to do, whether you have it or not, and for those of you on YouTube or Facebook, if you need this, the copy of the presentation, just send us a message at connect@levelupmedic.com. We can make sure we get that. After this broadcast ends, I'll actually post it on YouTube. So it'll be one of the pinned comments at the top of the YouTube channel. But regardless of where you are, whether it's YouTube, Zoom, or Facebook, what I still want you to do is I want you to stay active. I want you to participate. If you have a question, ask me, but I want you to stay as engaged as possible, okay? Somebody confirm for me on Zoom that you have the presentation. It should be in the chat. Oh, it looks like it's still coming. Okay. All right. So we'll give you just a few seconds for that to be able to access that. It's not so important that you're writing down everything right now as I'm talking. We have a short amount of time together today, so I'm just going to have to kind of keep it moving. All right. Do you guys have it? It looks like it's in the chat. Okay. All right. And for those of you on Zoom, I want you to, because I can see you, I want you to give me a thumbs up. Use the reactions button at the bottom of your screen and that kind of thing. All right, so today's topic is neurological emergencies. We're just going to jump right into it. And this is a really, really important topic because, especially for EMS providers, emergency providers, you will go on a lot of trauma calls, head injuries, things like that. These are very serious calls where the patient can rapidly deteriorate. And we're going to talk about why that is today. So, this is a big topic. I believe it was shout out to my man Thomas last week during office hours. Thomas was like, hey, coach, do you think we could go over spinal cord injuries? And I was like, you know what? We were running up against time. That was at the end of the session last week. And I said, hey, this would be a great session to do a full session on because it's a lot going on. So shout out to Thomas. That's how we're able to do this today. All right, so neurological emergencies. We're going to start off just talking about what are our objectives today. I'll just kind of go through this. You have this on your screen. We want to talk about, okay, what are the major structures of the neurological system, okay? And we'll divide that into central nervous system and peripheral nervous system. We'll further divide peripheral nervous system, okay? So we want to know kind of the main structures. What are the main players on the team? Then we want to talk about, okay, what are the different functions of the different parts of the brain? What does each part of the brain do? Okay. The reason you want to know this is because if somebody has an injury to a certain part of the brain, it's obviously going to cause, or it's likely to cause, some kind of deficit. So you hit a certain part or you wipe out a certain part, whatever that part does, whatever its job, it's not going to be able to do it as well because it got injured. Okay. We'll talk about cranial nerves, and it's not so much that you just memorize a list of cranial nerves, it's that you understand how to recognize the deficit. Okay, if a cranial nerve gets damaged, what kind of problem is it going to cause? And that's kind of what's most important. Now, some of this we did talk about last week for those of you who were with us, but we have a new audience today. And let me back up for a second. For those of you who don't know me, just give me just a moment. We'll take about 30 seconds here. For those of you who this is your first time seeing me, if you're on YouTube, let me know. Is this your first time ever hearing me, seeing me? So, who am I? I'm Coach Joshua. I'm a graduate trained certified flight paramedic. I've been in healthcare for 2 decades. I've taught over 2,000 people. So, in my EMS career, I was an EMT intermediate, a paramedic, a level 2 instructor, level 3, which is the highest level. I went on to become a flight paramedic. Then I went to medical school, and now I'm completing my training, my doctorate to be an emergency physician. So, in other words, I'm well qualified to help you. Okay. So now that's enough on me. Let's get back to the scheduled show. All right, so I want you to figure out what's the difference between a primary and a secondary brain injury. And I'm going to draw it out like a timeline for you so that you can kind of see when each thing happens. Hey, Jessica, I see you here. Welcome. Welcome back. We're going to talk about how to differentiate different TBIs or different types of traumatic brain injuries. In fact, let me blow that up a little so I can see it a little better. We'll talk about number 7 here. You hear so much about intracranial pressure and herniation. We're going to talk about ICP and why that matters. We'll get into Cushing's triad. They're like, this is a heavy topic. This is why I needed a whole session on this one today. We'll talk about, so as nerve impulses travel up or down the spinal cord, how does all that happen? So what's the motor input? What's the sensory input? Which way do they go? We'll talk about that. We'll talk about dermatomes and how to, it's not so much that you know every single dermatome, but it's that you know a few. So I'm going to give you about 8 to know. You don't have to know them all, but these 8 will kind of cover most of the, or at least large sections of those nerves. We'll talk about, so if somebody has a spinal cord injury, what kind of problem are they going to have? So we'll get into complete and incomplete spinal cord injuries. We'll talk about things like anterior cord, central cord, posterior cord, brown cord, that kind of stuff. All right, we're going to talk about, so I just said that, complete and incomplete spinal cord injuries. We'll talk about what's the difference between spinal shock versus neurogenic shock, okay? We'll also go into, we'll get briefly into how to do a neurological assessment, or at least the things that you're looking for as you're doing that assessment. And finally, we want to talk about, okay, what's your job? So as an EMS provider, what are you mainly going to do? Because some things are going to have to be left to the neurologist or the neurosurgeon, but there's some things that you can do. All right, so enough of that. We got a lot to cover in a short amount of time, so we got to keep it moving. Everybody good so far? Give me a thumbs up. Let me know that, show me some kind of love in the chat for those of you. Hey, Maris. Maris is joining us on Facebook. Hey, welcome. For those of you on YouTube, let me know that you're still with me and that we're ready to go. Are we good? All right, let's keep it moving. So let's start off with a scenario. And let's just take here, so that I am not doing all the talking. Is that Winchell? Is that you? Or who's Zoom user? I don't know what your name is, but who's that? Can you unmute for me?
Hey, I'm sorry.
Hey, what's your name?
Hey, I'm sorry. My name is Tyrese.
Tyrese, hey, how you doing? Well, welcome.
well,
Tyrese is actually one of our new students who just joined us. Hey, let's see if I can pop you in the box for me so everybody can see you.
Okay.
And you good with that?
Yeah, I'm fine.
All right. My man says, hey, he is ready. So, so Tyrese, let's see if I can get you to show up for me. I need a sip of water, so I'm gonna have you just help me read this for just a moment. All right, Tyrese, let's see if we can. All right, we got you there. I want you to just read this scenario for us. So let everybody know who is our patient here.
Okay. 24-year-old unrestrained driver strikes a tree. He initially speaks to responders, but become increasingly confused. He has a scalp laceration, one pupil larger than the other, a heart rate of 52, blood pressure 188/96, and irregular respirations. He is withdrawing from the left side from pain, but does not move his right.
So for those of you, so you're new with us, so you may not know this yet, but for those of you who've been with us for a while, you should know this. All right, so when we talk about our 5-star medic method, okay, so these are our top priorities for how we handle every kind of call, every type of real patient. We're going to use this kind of paradigm or this framework. The number one thing is a safety concern, okay? So we have an unrestrained driver. This is an MVC. We probably, there could potentially be some kind of safety concern. Type in the chat, what kind of safety concerns could we have on an MVC? Hey, Diamond from Detroit, welcome. Diamond is joining us from YouTube today. All right, so Becca says that we could have a traffic concern. We could have vehicle fluids, gas leak, Troy says. Yes, absolutely. All of those. We could have other pedestrians who just trying to see what's going on, nosy neighbors kind of thing. So we could absolutely have safety concerns. If you're doing this on a test question, then yes, we definitely want to take care of those safety concerns. Point number two is we got to immediately figure out, is this patient sick or not sick? In this case, Tyrese, do you
Yes,
think
sir.
this patient is sick
Yes,
or
sir.
not sick?
Very much sick.
Very much sick. Okay. So this patient, he is confused. We're going to call that altered mental status. He's bradycardic. He's hypertensive, has irregular respirations. All right. Now he has a, did I see something about pupils? Yeah. One pupil is larger than the other. What's that called, by the way? What's the term for that? Anybody type it in the chat. What's the term for when one pupil is a different size than another pupil, a different diameter?
That I don't know.
All right, the term for that is anisocoria. And we'll talk about that as we get further in the program, but anisocoria is the term for that. All right, this patient has irregular respirations, whether it's Cheyne-Stokes or Biots or apneutic or ataxic, it doesn't matter. They have some kind of abnormal breathing, and that's actually what would kill this patient first. There are a lot of things that could go wrong, but the thing that's going to kill this patient first is this irregular respiration. So this patient is definitely sick. Point number three, we figure out, is this patient stable? Well, actually, let's put unstable in red. We figure out, is this patient stable or unstable? Tyrese, would you say this patient is stable or unstable based on all these
Unstable.
signs that he's having?
Unstable.
That he's unstable. So here's what we know. If he's sick, that means we got to do something. That means we got to treat compared to not treat. If he's unstable, that means we need to do something now and initiate rapid transport. Point number four is, do we fix something or do we support him? For those of you in the community with me, you know this. All fixes come down to one of three things. I don't care what kind of call it is for your whole career, it comes down to we got to fix three things. One of three, two of three, or all three. What are those three things? Thomas says it's oxygenation, ventilation, or perfusion. Now, for those of you who are new to our world, you probably learned things like airway, breathing, circulation. But for the rest of you, we're going to call that oxygenation, ventilation, perfusion. All right, good job, Tyrese. Let's take you out for just a moment. All right, don't go anywhere because we'll come back to you.
Yes, sir.
Right, so now, and then finally, point number five is there a time-sensitive issue? In this case, this is probably time-sensitive. This patient probably needs to get to a level 1 trauma center. So it may mean that this patient needs to be airlifted if there is no level 1 trauma facility, within an hour or 30 minutes to an hour based on your protocols. But it would be better for this patient to go ahead and get to the trauma center right away, as opposed to going to just kind of a lower level center hospital and then having to be transported, because now that's going to take potentially more hours. So we want to get this patient to the appropriate facility or the most appropriate facility right in the beginning. Tanija, how you doing today? I see you here. Welcome. All right, so now let's keep going. So let's go. All right, so here's our scenario. We got this unrestrained driver. It seems like he's sick, he's unstable. Now, what is the immediate life threat? And I already kind of said this. Type it in the chat. What's the immediate threat that's going to kill this patient right away? A lot of things could injure this patient. A lot of things could end their life. But what's the main thing right away? So if I got to pick one, what's the main thing here? Okay, the irregular respirations. Becca and Brendan, good job on that one. So that's the immediate life threat. Now, which of these findings says that there's something going on with his brain, some kind of brain compression? Well, the fact that he has irregular respirations, that means that this situation has gotten, not only is it bad, it's gotten way worse. And we also Thomas says he's got some changes in his eyes. He has that anisocoria we were talking about, where one pupil is much larger than the other. So we probably have like a blown pupil type situation, okay? So this unequal pupils, you don't see what I'm doing. This unequal pupils, and by the way, I'm looking at multiple screens. I've got 5 screens that I'm having to look at. So sometimes I don't realize that something I'm showing is not on the screen. If you don't see it, just somebody on Zoom unmute and let me know. So this unequal pupils, that anisocoria we were talking about, definitely says that this is a head injury, more than likely, and it's definitely serious. Okay, we're also going to look for things like posturing, so decorticate or decerebrate posturing. We'll talk about that. Now, somebody answer me. Why is his heart rate slow? it doesn't necessarily, like, nothing else in the story points to any other like major stuff going on for the rest of his body. It seems kind of mostly in his face and more neurological. So what's going on with his heart rate? Why is his heart rate is 52? Why is that? Okay, Thomas, man, Thomas showing off. Okay, all right, check you out. So Thomas talks about reflex bradycardia. That's one of the things that happens in Cushing's reflex or Cushing's response, and we'll talk about Cushing's triad. All right, could this patient also have a cervical spine injury? So something with their C spine. Could there? Okay, absolutely. There, so many nerves originate from the cervical spine, and then some of the cranial nerves kind of pass through there. So yeah, all kinds of things can happen. All right, so let's keep it moving. And for those of you who are joining us on Zoom, I did post this presentation in the chat, but you're going to have access to it later. For those of you on Facebook or YouTube, there again, you'll have access to it. So I really want you to just kind of follow me. Don't necessarily worry about taking notes. You're going to see, for those of you who are just joining me, or for those of you who know me already, you know I draw pictures constantly. I think that's the best way for you to learn. As I often say, that when you can teach it back and when you can draw it. Becca, I just said this to you yesterday. Uh, I posted a video of Becca. She's one of our students in the community. She did a video on hyperkalemia and another one on acid base that I saw. And she was at the whiteboard drawing it out. And that's one of the best things that you can do. As I say, when you can teach it back and when you can draw it, that's when you understand it. All right, so let's keep it going. We got a lot to cover today. So let's talk about the big picture of the nervous system. So when you hear the nervous system, there's some terms that you want to know, okay? We want to talk about like the CNS, that's the central nervous system. So if you're filling this in with me, CNS, this is the central nervous system. PNS, all right, what is that? What's PNS? Type it in the chat. Let's see those fast fingers. PNS is, all right, Thomas, I don't know what you just spelled, but I think you're trying to say peripheral. So yes, that if you guys could see what this man just spelled, we're just gonna let that slide, but that's okay. So that's a peripheral nervous system. Now, when it comes to nerves and how things move, we have what's called sensory input, and then we have motor input. I'm going to explain all of this. I'm going to give you a picture of all of this. Don't worry. And then we also have a division of the peripheral nervous system called the autonomic nervous system. So these are just some vocabulary terms to know. Now, let's get into it. So, oh, wait. Hang on a second. I just realized, wait, let me see something. Oh, bear with me just a moment. I just pulled out I pulled up the wrong deck. There are no pictures. All right, so now I got the right one. I was like, wait a minute, there should be a whole bunch of pictures. Okay, here we go. So now let's talk about, let's make sure you can see this and see me at the same time. So let's say here's your person, here's your patient, or this is you. Okay. Now we have what's called the central nervous system. The central nervous system. So let's put that in. So I have central here. Or first of all, let me just kind of orient you. So when it comes to the nervous system, we have two main divisions. Those main divisions are the central nervous system and the peripheral nervous system. Okay. Now the central nervous system consists of the brain, the spinal cord, the cranial nerves. Central nervous system is going to be the brain, the spinal cord, and then the cranial nerves that originate up here. Okay, so that's central nervous system. What three things? Brain, cranial nerves, spinal cord. That's central nervous system. Now, when it comes to the peripheral nervous system, what is that? The peripheral nervous system is how messages go like from the brain or from the spinal cord, more specifically from the spinal cord to the rest of the body. So you see all this stuff that I have in purple here. These are peripheral nerves that messages can go toward or away from. Now, so I want to draw your attention to this part about sensory and motor. So if a signal is going from the spinal cord back up to the brain, okay, it travels along. That's what's called a sensory input, or that's a sensory nerve. So senses are things that, like your senses. So being able to feel, being able to like, okay, what are different things that you can feel though? This sense called touch has a lot of subtypes. So we have what's called discriminative touch, 2-point discrimination, fine touch or light touch, pressure, vibration, pain, temperature. All of those are things that you can feel. Those are all senses. So when the signal goes from the spinal cord up to the brain, it travels along a sensory nerve. But when it goes the other way, so notice how I have the S going up, or this is an S and not a dollar sign. So the S for sensory, the sensation is going up, okay? Or you could think of this as a dollar sign, and we want our money to keep going up. Okay, so S for sensory. But if we have a signal going from the brain down to the spinal cord, it travels along a motor nerve. So we have two ways that it goes. If it goes up, it's going primarily through a sensory nerve. If it's going down from the brain to the spinal cord, then it's traveling primarily along a motor nerve. Everybody good with that part so far? And for most of you, this part should be review. But now, this peripheral nervous system gets further divided. So central nervous system is brain, cranial nerve, spinal cord. Peripheral nervous system has two separate divisions. How many divisions for a peripheral nervous system? Two primary divisions, okay? And those two primary divisions are going to be what's called the autonomic nervous system as well as the somatic nervous system. Now, what's what? I'm going to zoom in on this for you just a little bit. So, hold on. All right, there we go. So let's talk about this autonomic nervous system. So the autonomic nervous system controls, think of it as like your involuntary nervous system. All the stuff that you need to keep you alive, you need that bad boy working all the time. And you don't want to have to think about it. You don't want, imagine if you forgot to say, oh, dang, what am I supposed to be doing right now? Oh, breathing. What if you just forgot to breathe? Or what if you just forgot to power up your GI tract? Or what if you just forgot to pump your heart, right? We need those things to just happen. Now, I don't know your beliefs. I happen to be Christian, and I just believe that God designed us so well that the human body is the most complex machine ever created. And it's amazing just what the body can do and all the little details that have to work for our body to be powered up every day. So here's what I'm going to say. So the autonomic nervous system, it controls things like your heartbeat, okay? It controls your digestion. It controls your breathing. It also it helps to regulate your blood pressure by either causing vasodilation of blood vessels or vasoconstriction of blood vessels, okay? All of those are going to affect what's called your systemic vascular resistance, and that's in turn going to affect your blood pressure. So what does the autonomic nervous system do? Controls your heartbeat, digestion, breathing, blood pressure, and a lot of other functions, okay? Wakefulness and stuff like that. All right, now the somatic nervous system, which is the other division of the peripheral nervous system. This is what controls more voluntary functions. Like if I want to pick up something right now and use my voluntary or skeletal muscles, the somatic nervous system is what's doing that. So it's mainly powering up your skeletal muscles, okay? So now your cardiac muscle or smooth muscle, whether that's talking smooth muscle around blood vessels, smooth muscles in the respiratory tract, smooth muscle in the GI tract. So notice that cardiac and smooth muscle are primarily under autonomic control, but skeletal muscle is primarily under somatic control. Okay. Now, what is another difference here? One big difference is with the somatic, the primary neurotransmitter involved there is the neurotransmitter called acetylcholine. We'll get more into that in a moment. Okay, now let's talk about this autonomic nervous system. The autonomic, which is a division, so here we are. Remember, peripheral is autonomic, which is involuntary, and somatic, which is voluntary. But this autonomic gets divided again, and the autonomic gets divided into the sympathetic and the parasympathetic, okay? What does the sympathetic do? What's a way that we remember the sympathetic nervous system? What's kind of our term for that? It controls what? What kind of response? Somebody type it in the chat. Your sympathetic.
Fight or flight.
Fight or flight, okay. All right, so your fight or flight response is your sympathetic response, where typically things are gonna like speed up, heart rate's gonna increase, blood pressure is going to increase, respirations are going to increase, things like that. Digestion is gonna slow down, pupils are going to dilate, All right, think about it. Think about your fight or flight response as, hey, you're running from a bear. Now, I don't know where you live, but let's just say you're running from a bear. If you're running from a bear, you need your muscles to work quickly so that they can move. You need your heart rate to go up so that you can send more blood to those muscles. You need to breathe faster so that you get more oxygen to the muscles and to the brain primarily. But when it comes to if you're running from a bear, do you need more light coming into your eyes so you can see, or less light so you can't see? Do you want to see if you're running from a bear, or it's not so important at that point? You need to see. So we need more light coming into our eye. Therefore, our pupils need to dilate. Okay. What's the term for pupil dilation? What's the word for it other than dilation? What's the actual term for pupil dilation compared to pupillary constriction? What's that term? All right, the term for pupil dilation, that's going to be mydriasis, and the term for pupil constriction is going to be miosis. Oh, check me out. Miosis. When does that happen? Give me two big things where we have pupillary constriction. A lot of things can cause it, but what are two big things that cause miosis or pinpoint pupils? Come on, students.
Overdose.
Opiate overdose and organophosphate poisoning. Okay, so when it comes to pupil constriction, we're thinking primarily opiate overdose, organophosphate poisoning. Yes, a lot of things can do it, but those are the two big things I want you to think about. When it comes to pupil dilation, though, mydriasis, it could be a lot of different things. It could be a head injury. It could be other overdoses, other illicit substances. Lots of things could do it. All right, so let's get back to where we were. This sympathetic nervous system, this Becca says organophosphate is a longer word to type. I get it. So the sympathetic nervous system, your fight or flight, your parasympathetic is your rest and digest or feed and breed, however you want to say it. Now, here's you may or may not know this part, but if you're just interested, what's the big difference in how messages travel along the sympathetic nervous system compared to how they travel along the parasympathetic? Okay, we have two nerve fibers. Okay, so this is a picture of a nerve. Here's what you want to know. Let's keep it simple for purposes of this. If I'm talking to medical students, we'll go a lot more in detail on this. But here's what I want you to know. In the sympathetic, the first fiber is a short, it's a short neuron. Okay, so notice I have this one is short and this one is long. Okay, in sympathetic, the first one is short, the second one is long. So what has to happen is this signal, this nerve impulse has to travel from here. So starting right here at the axon hillock, and then it goes through the terminal bouton. And what happens is, so right there I have ACH, that's acetylcholine. So what has to happen is acetylcholine gets released into this neuromuscular junction. Then it activates this next neuron, and then that nerve impulse now spreads. So we have this wave of depolarization that spreads along here, and then it causes the release of norepi. Okay, so the two notice the difference here. Under the sympathetic, the two neurotransmitters that are used are acetylcholine for the first one, norepi for the second one. Okay, the other difference is the first one is short, the second one is long. And this travels primarily through the thoracolumbar nerve. So what does that mean? That is the nerves coming from the thorax, so around the chest cavity and abdomen, and then the lower back, the lumbar area. Okay, so kind of through here, this is where the nerve stimulus starts. This is the origin of the nerve for sympathetic responses. It's kind of coming through this main area. So imagine if somebody has some kind of trauma to this area. Now it could interfere with those nerves being able to work properly, and they may not have the sympathetic activation that they're supposed to have. Is everybody with me on that? And for purposes of today, that's about as far as I need to go. I could literally spend another 4 hours on just this one topic alone. Now, let's talk about the parasympathetic and what's the difference. When you need to calm things down, we're going to primarily use a different set of nerve origin, and this is what's called the craniosacral nerve. So where is that? So the cranial nerves are way up here. The sacral nerves are way down here at the sacrum. Okay, so notice for sympathetic, most of our nerve origin is kind of in this region, but for parasympathetic, it's kind of in this region. Okay, now what's the difference though on the parasympathetic side? The first nerve impulse is long and the second one is short. And what is the neurotransmitter that gets released there? It's acetylcholine in both. Now, I just drew it in a picture so it's easier to kind of see a lot of information at one time versus just reading all of this. So notice the difference. Under the sympathetic, we have acetylcholine and norepi as the neurotransmitter. And then the adrenal glands also get involved. And the adrenal glands, so this is your kidney, and then sitting on top of the kidney is the adrenal. And then the adrenal gland has kind of this outside part, and then this innermost part that I have in red, that's the adrenal medulla. That's the part that makes your epi and norepi. So those hormones that have to circulate through the blood, they're going to come here. So when we need sympathetic stuff, like we need stuff to speed up, we need acetylcholine to get released, we need norepi to get released through this neuromuscular junction, but we also need the adrenal gland to also secrete some more norepi and some epi in the bloodstream. Okay? All right, that's about as far as I need to go for that part. Now, let's talk about first of all, any questions so far? I know I'm kind of speeding through this. It's just we got a lot to cover in a short amount of time. Questions so far? Is this making sense? Okay, so here, for those of you on Zoom, just unmute for me, unless your background is noisy, and then you stay quiet. So everybody just unmute for me for those of you on Zoom so that the people on YouTube and Facebook can hear you guys and know I'm not actually just talking to myself. So let's go, Jessica. So Jessica, in the sympathetic, let's go, Jessica. In the sympathetic activation, what's the first neurotransmitter that gets released?
I'm gonna be honest, I was half paying attention, but it's
goodness.
norepi if I remember correctly.
Okay, so in the sympathetic,
Oh, that's gonna be parasympathetic.
Okay,
I've got the other way.
In sympathetic, the first neurotransmitter that gets released is acetylcholine. The second one that gets released is norepi. On the parasympathetic, for the first and second is acetylcholine. Okay, and then for the somatic, the neurotransmitter is acetylcholine. So notice how much acetylcholine gets. We need acetylcholine as a neurotransmitter for a lot of different situations happening. Okay. But they could have, let's say they have a disorder or some kind of process where acetylcholine is being degraded. Let's say things like myasthenia gravis and all of that. Now there's not as much acetylcholine laying around. And so look at all the different situations that could potentially be wiped out in something like myasthenia gravis or Lambert-Eaton myasthenic syndrome, stuff like that. All right, now let's move on from that. How is the brain protected? So the brain is inside of the hard bone, that hard bone that's on the outside of the brain, that's your skull, of course, or some refer to it as the cranium, or the cranial vault is kind of that space. But here's kind of let's kind of orient you. So here's your brain. So this part that I have on the inside here, this is your brain. Okay. And the brain is divided up into two hemispheres. So if this patient is facing me, this is the left hemisphere, and then this is the right hemisphere if the patient is facing me. Okay. Then on the outside of the brain, we have the skull, so the cranium. Now let's kind of zoom in on this section right here. All right. So if I zoom in right here, let's kind of talk about these different layers. So we have this part right here on the outside. So that's the skull. Okay. And that's kind of if I zoom in even more, we can kind of see this bony structure of the skull. Now, right below that is what's called the dura. Okay. Or the duramater. Duramater. So it means it translates to hard mother, but this is a very hard section to kind of protect the brain, because we don't want the brain we don't want something constantly like pressing on it, or also we don't want the brain, the shape of the brain to change and that kind of thing. So we need something that's more rigid on the outside of the brain to keep it protected. We also don't want things easily getting to the brain. okay, especially from the outside. So there's this hard layer, the duramater on the outside, and then right below that, we have, so somebody tell me, anybody know what this next layer is?
Arachnoid.
Okay, so we have the arachnoid layer, or the arachnoid mater, and this is where this kind of bluish part in here, this is the cerebrospinal fluid that kind of floats through there. Because so all this blue that's around here, the brain is kind of bathed in this, or floating kind of, so to speak. It's not like free floating, but we're just going to say it's kind of bathing or floating in this cerebrospinal fluid. So that serves as like a shock absorber, an insulator to kind of regulate the temperature and all of that, but also prevent shocks from happening to the brain. Now, that cerebrospinal fluid kind of continues, and it also bathes the spinal cord. Okay, so we have the duramater, we have the arachnoid mater, and then the very thin part, so it's on this, it's kind of in green, this very thin part that actually covers the tissue of the brain itself, that's called the pia mater, or soft mother. So this is the pia mater, okay? And notice that we also have arteries running through here, we have veins running through here, so we got to have blood supply some kind of way to get blood to the brain, okay? Then we have our gray matter. So our gray matter, which is primarily made up of cell bodies. And then we have our white matter of the brain, which is primarily made up of axons. So gray matter, mainly cell bodies. White matter, mainly axons. Now, what does that even mean? Let's go back to this nerve for just a moment. So this part right here, let me just draw it in. This is the cell body. So what I'm drawing right here, this is the cell body. And then the axon is this kind of long section here. That's the axon. So the white matter is mainly made up of these axons, and then the gray matter is mainly made up of these cell bodies. All right, let's keep it moving. So these layers that surround and protect the brain, these are what are called the meningeal layers, okay? So there are three primary meninges, or meningeal layers. Those are the dura mater, the arachnoid mater, and the pia mater, okay? Those are the three meningeal layers. But what do you call it if we get some kind of infection, maybe a bacterial infection or a viral infection that wipes out the meninges? What's that called? If we get some kind of infection that causes inflammation, that's going to be itis. And then if I put meninges with itis, what is that called? That's meningitis.
Meningitis.
So meningitis could be due to a bacterial infection. It could be due to a viral infection. If you have somebody with suspected meningitis, so some kind of suspected inflammation to those meningeal layers, what kind of precautions do you need to take? What kind of PPE, body substance isolation? So remember our BSI, scene safety. What's the BSI stuff we need for suspected meningitis? Whether it's viral or bacterial, we don't know yet until a lumbar puncture is done. N95, especially for you, and then at least a surgical mask for your patient. If you have an N95 where both people can wear it, that's even better. But definitely you want to protect yourself with an N95 mask. Okay. Okay. All right. So that's good. Everybody good on that? How many meningeal layers are there? Oh, I just said it. How many meningeal layers? YouTube too. I need some love on YouTube and Facebook. So YouTube and Facebook, how many meningeal layers are there? Alex on Facebook, what you got? I think Alex is asleep. How many meningeal layers? Type it in the chat, everybody. Okay. Tyrese says 3. No problem. All right, let's keep it moving. Now, I want to talk about the next topic we're going to talk about is intracranial pressure. You hear so much about ICP. Man, their ICP is going up. They've got rising ICP. So we're going to talk about ICP and what's called the Monroe-Kelly doctrine, or the Monroe-Kelly concept. So first of all, let's kind of simplify it. All right, thanks, Alex on Facebook. I appreciate that, my man. Well, I don't know if Alex is male or female, but Alex, whoever you are, thank you. So, okay, let's mute everybody for just a moment, because somebody's having a whole conversation that has nothing to do with increased intracranial pressure. All right, so let's keep going. Imagine the skull is like a box, okay? Imagine the head, the cranial vault, the skull is like a box, right? The thing about this box is you can only put so much in this box. So so the way it works is so let's kind of orient you. You've got so this kind of black part in the middle here. So this outside, this is the actual skull. Now, this kind of black part, this part in the center, we're going to say that's the brain. This part in red, that's the blood. And this part in blue, that's the cerebrospinal fluid. So kind of in that space, in this box, if you will, we got a brain, we got blood, we got cerebrospinal fluid. Well, we can only fit so much. So here's kind of the big picture of the Monroe-Kelly doctrine. It says that, okay, you have a closed container. If we get more of one thing, everything else has to compensate for it. Okay, so if we get more of, let's say if we get more cerebrospinal fluid, well, now that's taking up space from the other two. So they're going to have to compensate. Well, the brain is like the brain. Like the brain can't just shrink suddenly. We wouldn't want that to happen. But what does happen is as we put more and more stuff in that space, so as we put more and more stuff in that closed space, the pressure changes inside that space. Is everybody following me there? Okay. Only so much can fit. And if I keep putting more and more stuff in that thick space, it's got to go somewhere. One thing that happens is the pressure changes. So that's exactly what happens in the situation of increased intracranial pressure. So here, this is where everything is in like perfect harmony. So the brain takes up about 80% of the space. The blood takes up about 10%. So now we're up to 90. And then the cerebrospinal fluid takes up the other 10. So we got an 80-10-10 kind of arrangement or ratio. That's how we want it to be. That's what's supposed to happen. But let's say somebody gets a head injury. They get hit with the baseball bat. Or this guy, he said the wrong thing. His girlfriend just hit him with a frying pan. Whatever the case was, let's say he's now bleeding. Well, now, remember, we can only put so much in this space. Well, now, let's say I put a whole bunch of blood in this space, more than the 10% that's supposed to be there. Well, it's got to go somewhere. So what it does is it starts pressing on the brain, okay? And now the pressure inside the cranial vault is going to increase. So now we have increased intracranial pressure. The same could be true if we have more cerebrospinal fluid than we should have. If the cerebrospinal fluid is taking up more than the 10%, now we have increased intracranial pressure. And I'll give you an equation so we can make sense of this. All right, any questions so far? We got to keep it moving though. Any questions? Is anybody learning so far? All of this, I know this is kind of foundational stuff, but we need to know this to get to like where we're going next. Anybody learning so far? Give me a thumbs up on Zoom. If we're learning, if not, give me a thumbs down. I'm fine either way. I just need to know. Okay, nice. And for those of you on Facebook and YouTube, how are we doing? Like, are you still with me? YouTube, Facebook, I need something. I need to know if you're still with me. Otherwise, we're gonna shut this down, and we're sending you back home to your mama. All right, let's keep going. So let's get back to it. We want to talk about primary versus secondary brain injuries. And this is something that's so important. So when you have a trauma patient, okay, Alex, you said no? Alex says no what? No, you're not with me, or no, we're not, you don't want to shut it down? Is that no? And for those of you on okay, you got to give me more than that, because I don't know. I don't know what the question was that you're answering, just because there's a delay in when I see the message. So let's just keep going. The reason this stuff is so important, when you go on a trauma patient, so in this scenario, we have this 24-year-old who was an unrestrained driver. We've got a head injury and all of that. You don't just have the first injury. There are additional injuries that happen afterwards. So we kind of have like a primary and then a secondary injury, and you've got to be prepared for both. You got to be looking out for all these other things that can happen. You know how like in an anaphylactic reaction, you have the initial things that happen, but as more histamine gets released, as more leukotrienes get released, you're going to have these kind of delayed reactions. This is why you don't want to just immediately treat somebody with an anaphylactic reaction and then get a refusal and send them back home. Same with a head injury. If you go on a call, you don't want to be so quick trying to get a refusal. I know sometimes you want to get back to your lunch or your dinner. You've run 12 calls in the last 6 hours and you're tired, right? But don't be so quick to get a refusal, especially on like these head injuries or these neurological type emergency patients, because you can have the initial injury. It also depends on how long did it take you to get there. That's going to determine how long it takes for some of these other things to start happening. So be very cautious on just getting a refusal and releasing the patient, because they could be fine 1 minute and dead in like 30 minutes. Okay. So when it comes to this primary and secondary injury, the way I want you to think of it is the primary injury. So here's like a timeline. So here's the initial impact. So we would say the mechanism of injury. So whatever it was that caused the problem, whether it was a car accident, whether it was some other blunt force trauma, whether it was penetrating trauma, you got something that caused some kind of impact. So the stuff that happens, or the part of the brain that suffers initially, that's the primary injury. But later, and the time period will vary from person to person. It also depends on how severe it is. So severity is a major factor here. But then we have the secondary injury that can happen. Now, some examples of these secondary injuries are things like hypoxia. Okay, so a lack of oxygen, respiratory depression. So now they have maybe a herniation and their brainstem is being affected. They could go into respiratory failure, where now they're not ventilating properly. They're holding on to all this CO2. That CO2 behaves like an acid, puts them in a state of acidosis. Acidosis causes vasodilation. It dilates the blood vessels and sends them into shock. So they can go from hypoxia to respiratory depression, respiratory failure. They can eventually go into shock and have profound hypotension because the brain is affected. They could have seizures. They could have all kind of swelling, or we could have increased intracranial pressure. If that pressure starts pushing on the optic disc, now it causes papilledema, things like that. They could have all kinds of oxygenation, ventilation, perfusion problems. So long story short is you want to be watching out for all the things that potentially could happen. You need to be anticipating that. You don't want to wait until it happens. You want to prevent these things from happening. Okay? Everybody good with that? Let's keep it moving. Let's talk about the main regions of the brain. And you can go back and fill this in your presentation. Let's talk about the main stuff in the brain. So we have a frontal lobe, we have a parietal lobe, we have a temporal lobe, and an occipital lobe, okay? Now, I also have some information here. So the frontal lobe, some things that it does or things that it controls are things like judgment, personality, being able to plan things out, motor control, especially more fine motor control, speech production. So in fact, speech production, so let's, in red here, this part, so let's orient you first. Here's your head. The outside is your skull. The inside is your brain. Okay, this is the front or the anterior part. This is the back or the posterior part. Now, up here in the front, we have what's called the frontal lobe. Okay, so this is the frontal lobe in the front. I just have kind of a light bulb for like thinking, that kind of thing. But in this little part over here, kind of on the front on the left, this little section right here is called Broca's area, B-R-O-C-A, Broca. This is the part that's primarily involved in speech production, like you being able to formulate your words and speak. So Broca's area. So let's say somebody has a stroke and they wipe out Broca's area. They're probably not going to have, they're not going to be able to speak as well. They have, what type of aphasia is that? We talked about this last class. What type of aphasia is it when they can't speak? There are two types of aphasia. One is where they can't understand. The other is where they can't speak. Which one is where they can't speak? Okay, so the word that you wrote, Jeff, notice how it's spelled. That has a G in it. That's actually a problem with swallowing and not speaking. Okay, you put dysphagia with a G, that's swallowing and not speaking. Phasia has an S, so let me just write it out. The word is aphasia. We either have expressive or we have receptive. Expressive aphasia is where you have trouble expressing yourself. So that's the speaking part. Receptive aphasia is where you have trouble receiving information or understanding information, processing it. But you want to know the difference between one has an S and one has a G. The one with the G, dysphagia, is a swallowing part, okay? But that's also something that could be wiped out, especially if they're having a stroke. So we have the frontal lobe. Then this part in blue here, this is what's called the parietal lobe. The parietal lobe deals with things like sensory interpretation. So that's how your body, like that's how the signal goes, it kind of comes through here and goes to the thalamus, the relay center. And that's how your body's able to process different senses like pain, temperature. Now, I'm not saying that's where the signal is coming from. I'm saying it has to go through there. Spatial awareness. This is kind of where your body is or where your body parts are in relation to the other. It's like my hand is higher than my feet, that kind of thing. And your brain recognizing that, that's coming from the parietal lobe. Then we have the temporal lobe. Notice I have an ear here for the temporal lobe. So big things there, and it's kind of close to the ear. So big things with the temporal lobe are things like hearing, memory. Now, memory is involved in multiple parts, but hearing, memory, language, comprehension, emotion. There again, emotion is also involved, like part of it is in the frontal lobe. Then we have this purple part, that's the occipital lobe. So that's all the way in the back. Notice I have a picture of an eye there. Vision, like visual acuity, being able to see, is primarily regulated through this portion of the brain. Okay. And then we have this part all the way in the back. This part all the way in the back, that's called the cerebellum. A lot of people talk about the cerebellum is involved in movement. It's not so much that the cerebellum is involved in movement. It's more skeletal muscles that are involved in movement, but the cerebellum is what allows you to move smoothly. Like instead of just wobbling all around, it allows you to be able to put like one foot in front of the other and have like a nice smooth walk, okay? So big things that you want to know in terms of the big structures of the brain. We've got the frontal lobe, we've got the parietal lobe, we have the temporal lobes, and then we have the occipital lobe, and then all the way in the back, kind of in the midline, is the cerebellum. All right, everybody good with that? So now let's keep going with this story. So let's talk about the cerebellum and the brainstem. So the cerebellum here, as I just said, this is the part that does smooth movement. And so coordination is the word that's often used, but that's being able to like walk in a coordinated fashion. Or let's say I go to pick up a water bottle. I don't want to just pick it up and throw it everywhere. I want to be able to nicely control the bottle, okay? So the cerebellum is helping me with that smooth movement. Then we also have, we have the cerebellum. Then we have these sections of the brainstem. We have the midbrain, the pons, and the medulla. Let's talk about it. So, and then, there's more to the story. We could get into like the ramencephalon, diencephalon, stuff like that. Right now, I just want to talk about this first section right here. This is called the midbrain, okay? This next section is called the pons, and then this next part is called the medulla, or officially the medulla oblongata from the movie Waterboy. So we have midbrain, we have pons, we have medulla. Now, lots of stuff is coordinated through these regions. So vision, part of vision kind of takes place in this area. Consciousness kind of takes place there. Breathing, especially down close, more in the medulla, more in this kind of pons medulla area. This is where breathing, your respiratory centers are located. This is how digestion is also affected through there. Your heart rate, how your body regulates your heart rate is affected through this brainstem. Vasodilation and vasoconstriction that regulates blood pressure, especially when we're talking about the baroreceptors. That's all in here. So what you want to know, the big takeaway here, is if somebody has an injury that messes up their brainstem, look at all the stuff that it can wipe out. Look at all the stuff that's involved in the autonomic nervous system that you need to keep you alive. This is why brain injuries or head injuries can be so dangerous, because they wipe out very important functions like Am I going to be able to control my blood pressure? Am I going to regulate my heart rate? Am I going to be able to breathe well? Okay, stuff like that. Any questions on that? Because we're just going to keep going with the story. Any questions so far? Let me know. Are we still learning? I don't want you sleeping. Jessica checked out on me. She's like, Coach, I'm not even paying attention. So what about the rest of you? Everybody still good? All right, so Jeff, let's hear from you. Jeff, let's bring you in for a moment. All right, let's find you so I can bring you in, Jeff. Jeff, if you'll just unmute so I can find you real quick.
I got you.
All right, let's see. Let's bring Jeff in. Actually, Jeff, there you go. All right, you're live, my man. The world is seeing you. Hey, so tell me from the top. So we've got the brain, and then we got the cerebellum in the back. What does the cerebellum do?
The cerebellum that controls like smooth muscles,
Smooth, like
and movement.
Smooth movement. Don't say smooth muscle.
Movement.
That's something different. But being able to being able to move smoothly. So that's your cerebellum. Okay. Now, as I start going down in the brainstem, what's the first section at the top of the brainstem? What's that called?
Midbrain.
Midbrain. And then what's underneath that?
You got pons.
Pons. And then what's underneath that?
Medulla oblongata.
Okay, the medulla oblongata. All right, nice. Check you out. All right, stay there, my man. We're going to go into cranial nerves. You ready? All right, so now let's start talking about cranial nerves, everybody. And I kind of talked about this. All right, Facebook says they're learning a lot. Now, YouTube, I don't know if YouTube is still there with me. But YouTube, I need you playing too. So now let's talk about cranial nerves. You hear so much about cranial nerves, and it's not so much that you remember like the name of them. Yes, it's helpful to know the name, but where we care the most is like, what kind of problems do they have? Okay. Like if one of these nerves is not working, or if multiple of these nerves are not working, what kind of problem is it going to lead to? So we have, when it comes to cranial nerves, cranial nerves, is this going to be a part of the central nervous system? Okay, it's cranial. Is that a part of central nervous system, or is that a part of peripheral nervous system? Type it in the chat for me. Type it in the chat. Central nervous system. So cranial nerves, is that going to be central nervous system or, okay. All right. So it looks like you guys got that. So yes, that's going to be the central nervous system. Remember, the central nervous system is the brain, the spinal cord, and the cranial nerves. We have 12 pairs of cranial nerves, okay? Each of these nerves do a different job. And we're going to go kind of deep into this. Just know right now we have 12 cranial nerves. Now, I'm going to go ahead and start you off. Well, I've actually got it written down for you. And just instead of me writing this, just in the interest of time, I'm just going to put it on the screen so you can see it. So cranial nerve 1 is called the olfactory nerve. Olfaction is your sense of smell, okay? You don't have to know this, but it kind of originates behind the cribriform plate. But cranial nerve 1 is olfactory. Cranial, and there are a lot of mnemonics people use to remember the names. Some are more explicit than others. Whatever works for you, however you learn to remember them, that's fine. Just use whatever you know. Cranial nerve number 1 is olfactory. Cranial nerve number 2 is optic. So this is about being able to see, like being able to actually get light going in, and the retina seeing the light. That signal goes along the optic nerve. So this is being able to see compared to being able to move your eyes. Now, moving your eyes is actually 3 sets of nerves. One of them is cranial nerve number 3. Okay, so Jeff, all right, cool. I like that, no problem. I think that's what I actually use in the comprehensive study guide. Jeff put a mnemonic for us. Cranial nerve number 3 is oculomotor. Okay, notice it has the word motor in it. Whenever we're talking about motor function, we're talking about something moving. So this is being able to move your eyes. Okay, now this is most of your eye movement, but there are 2 other cranial nerves that are involved in eye movement. Okay, the way I remember that, here, let me just tell you. Cranial nerve number 4 is trochlear, so that's pronounced trochlear. So this is being able to move your eye down and in. okay, as opposed to down and out. Okay, so this allows your eye to be able to look down and in. That's the trochlear nerve. Cranial nerve number 5 is the trigeminal nerve. It's called trigeminal because it actually has 3 branches that control different parts of the face. You have a branch that goes to the eye, you have a branch that goes to the upper jaw, cheekbone area near the zygoma, and then you have a branch that goes to the lower jaw. So trigeminal nerve, a condition that can happen when this nerve gets kind of spastic and starts spazzing out is trigeminal neuralgia, also known as tic douloureux. We have cranial nerve number 6, which is abducens, and this controls lateral eye movement. So when your eyes look out to the sides, lateral movement, that's the muscle is called the lateral rectus. Cranial nerve number 6 is what allows your eyes to move out. So here's the way I want you to remember it. There are 3 nerves that control eye movement. It's 3, 4, and 6. The way you remember this is 3, 4, and 6 make the eyes do tricks. Okay? 3, 4, 6. The stuff I come up with when I sit in a studio by myself for hours. Cranial nerves 3, 4, 6 make the eyes do tricks. All right, you got that? All right, the first time you say it, you got to give me credit for it. And then the next time, okay, you can have it. But cranial nerves 3, 4, 6 make the eyes do tricks. All right, you got it? Now, rather than just show you like a list, let's actually show you a face. All right, look at this handsome young man here. Okay. I don't know what's going on with his eyes. Wait a minute. What's that called when his eyes are like unequal? What's that called again? All right, type it in the chat. Quit. What's that called when the eyes are unequal? Oh, Thomas is on it. So that's going to be anisocoria. Anisocoria. Okay. Okay. Oh, you don't see what I'm doing. Anisocoria. Now, there's about a fifth of the population, about 20% of people out there in the world have this anyway. There's nothing wrong with them. It's just their eyes are not equal. So about 20% or a fifth of the population has what's called physiological anisocoria. Nothing's wrong with them. However, but typically it's like there's not a huge difference. It's not like one eye or one pupil is 5 millimeters and the other is 1. When you have those kind of differences, it may be like 1 is 3 and 1 is 4, or 1 is 2 and 1 is 3, but it's not like 1 is 1 and 1 is 5. When you have those kind of situations, that's pathological anisocoria. That's actually problematic. So that's what is typically associated with a head injury. Say it again, Becca. Oh, okay. Okay. Anisocoria. Yeah, that's how it's spelled, right? I think so. I'm pretty sure. If I'm wrong, that's okay. Just correct me. Anisocoria. I think that's anisocoria. I think that's how it's spelled. All right, so now let's talk about this. All right, so here's our guy here. Oh, sorry. Here's our guy. Okay. Now, here's this light, right? So when this light comes into the eye, so what cranial nerve is going to do that? Okay? That's going to be the light coming into the eye. That's going to be our cranial nerve number 2. Okay? But the eye being able to constrict, so being able to see the light is cranial nerve number 2. But this pupil that's very pinpoint, that's very constricted. What's that term again for that? That's going to be miosis. And the term for a very dilated pupil is mydriasis. Okay? Now, what makes the pupil constrict when light shines in the eye? That's going to be cranial nerve number 3. So the pupil constriction is cranial nerve number 3. Okay? What about our sense of smell here? Our sense of smell, that's going to be cranial nerve number 1. That's going to be our that's our olfactory nerve. Cranial nerve number 1 is olfactory, sense of smell. Cranial nerve number 2 is optic. Cranial nerve number 3 is oculomotor. Okay? Now, let's go to cranial nerve number 4. Cranial nerve number 4 is also involved in eye movement. So we have cranial nerves number 4. Remember, it's 3, 4, 6 make the eyes do tricks. So 3, 4, 6 also deal with eye movement. Okay, now let's go to cranial nerve number 5. So cranial nerve number 5 has 3. So it's Roman numeral V for 5. We have a division that kind of points over to the eye. We have a part that goes to the upper jaw. We have a part that goes to the lower part of the face. Okay, remember the condition that gets affected when cranial nerve number 5 gets wiped out? That's trigeminal neuralgia, also known as tic douloureux. Okay, this can cause lots of like spasms and what's called lancinating or shooting neuropathy. The drug of choice for that is going to be some kind of a sodium channel blocker, kind of like a carbamazepine or something like that. All right, so let's keep going. That's cranial nerve number 5. We also covered cranial nerve number 6. So far we've covered 1 through 6. Now let's talk about cranial nerve number 7. So cranial nerve number 7 is the facial nerve. It deals with muscles of facial expression. So when you when you do stuff like this, raise your eyebrows, when you frown up, when you make a kissing face, things like that. Like if I pucker up and go, okay, and I make these muscles work right here, the orbicularis oris muscles. I need a nerve to power up those muscles. That's going to be cranial nerve number 7. So facial expression is cranial nerve number 7. Okay, now let's go to cranial nerve number 8. Okay, this is the vestibulocochlear nerve. You've heard of people having maybe a cochlear implant that allows them to be able to hear. Cranial nerve number 8 is primarily the one that's involved in hearing and balance. So let's go ahead and put this in. Cranial nerve number 8 is hearing and balance. Cranial nerve number 7 is muscles of facial expression. Okay, so we got cranial nerve number 7 up here, cranial nerve number 7 here. Cranial nerve number 7 is involved in a lot of different things. Let's go cranial nerve number 8 we did. Cranial nerve number 9, the glossopharyngeal nerve. This is involved in swallowing, so let's put that one in. Cranial nerve number 9 is involved in swallowing. It's also involved in gag reflex. It's also involved in baroreceptors that regulate your blood pressure. So when somebody does a vagal maneuver, that's involving cranial nerve number 9 and cranial nerve number 10. When you get somebody to bear down or blow through a straw or blow through a syringe when they have stable symptomatic tachycardia, and you get them to do a vagal maneuver, we're activating cranial nerve number 9, cranial nerve number 10. Cranial nerve number 10 is the vagus nerve. It's the long nerve that's involved in a lot of stuff like your voice and activation of the larynx, being able to swallow. And then it's also involved in a lot of parasympathetic stuff, like when we need to slow down the heart rate, that's going to be vagus nerve, okay? So vagus nerve innervates a lot of different organs. Cranial nerve number 11, the spinal accessory nerve. So that's what allows you to be able to turn your head and shrug your shoulders. So let's put cranial nerve number 11 in here. And then the nerve that allows you to be able to move your tongue, stick out your tongue, that's going to be cranial nerve number 12. That's the hypoglossal nerve. Hypoglossal here. So tongue movement. So being able to stick out your tongue and wiggle your tongue around. Fun fact, your tongue, and try this. Just stand in your bathroom mirror, stick out your tongue, and see if you can control it. See if you can keep it perfectly still. The tongue is kind of always moving. It's always under involuntary control. You can override it and you can move it yourself. But when you just sit there and try it, just stand in a mirror and see, like stick out your tongue and see if it stays perfectly still. And you're going to find that there's this constant involuntary movement. Your tongue is always moving. Okay? So, excuse me. When you go to the doctor, and they say, stick out your tongue, and say, the stick out your tongue part, they're checking for cranial nerve number 12. When they say, they're checking for like cranial nerves 9 and 10, okay? All right, so what I want you to do is take a picture like this. Oh, you don't see what I'm doing. Take a picture like this, and you can always just draw this yourself. Draw your little, a nice, handsome man like this, or a nice, beautiful woman. And then I want you to put the corresponding cranial nerve on the face. All right, now let's keep it going. We got a lot more to get to. So we will be ending at the top of the hour, so we got a lot to cover. Now, let's talk about this whole pathway of how you see. Okay. Remember how I said that, like, if you shine a light in somebody's eye, them being able to see the light is cranial nerve number what? Type it in the chat. What cranial nerve allows you to see versus what 3 cranial nerves allow you to move your eyes? Cranial nerve number 2 is what allows you to see. What's the name of cranial nerve number 2? Type it in the chat, everybody. What's the name of cranial nerve number 2?
Optic.
Optic, okay. All right, so let's say I shine a light in somebody's eye, or just light goes into their eye just from the light or the sun or whatever. What allows you to see the light is cranial nerve number 2. But then what happens is that signal now goes, it travels along cranial nerve number 2, it goes to the brainstem, and then the signal gets relayed, and there's a whole physiologic process that happens between here. I'm simplifying it for today. This is another hour-long discussion, just this piece right here. Like this, there's a whole lot more involved, but for simplification for time today, I'm going to say it goes from cranial nerve number 2 to the brainstem to cranial nerve number 3. That is true. It's just there are about 10 more steps to it. Okay, so the signal has to go, it can't just go from one nerve to another nerve. It goes from the nerve to the brainstem to the nerve. Okay, but then once it gets to cranial nerve number 3, that's the one that actually causes the pupil to constrict so that you're not blinded by the light. So it blocks out how much light is able to enter. So cranial nerve number 2 allows you to see. It sends a signal to the brainstem, passes the message to cranial nerve number 3. Cranial nerve number 3 says, okay, I know what to do now. Oh, you want me to constrict so they don't get blinded. And then cranial nerve number 3, oculomotor, actually causes the pupil constriction. Everybody good with that? We good with that? Give me a thumbs up if we're good. I can't wait to get to spinal cord injuries, but I got to get there. Hold on, let's see. So Jeff asked, okay, so Jeff asked a question about the pupil differences. So since we're there, since we're on this page right now, when the pupil, so the normal pupil size, some books will say 2 millimeters, others will say 3 millimeters, okay? So that's kind of your normal pupil or pupillary diameter. What we don't want to see is we don't want to see pinpoint pupils, or we don't want to see blown pupils or significantly dilated. So you know how like in cardiac arrest, one of the things that can happen is depending on the timing, the pupils become fixed, meaning they don't dilate or constrict, but they're fixed, so they just stay in one position, and they stay dilated, so they're fixed and dilated. We don't want to see significant mydriasis or significant meiosis, or we don't want to see meiosis or mydriasis. So we don't want to see pinpoint. We don't want to see very dilated. What else you want to know? So there again, the word for this is meiosis. The word for this is mydriasis. If you have unequal pupils or anisocoria, especially if it's pathological, remember, some people normally have it. It's fine. Like there's no problem. But if they have pathological, where there's a big difference in one side versus the other, one is like very dilated, one is very constricted or pinpoint, that's pathological, most often associated with some type of head injury or some kind of traumatic brain injury. Okay? Did that answer your question, Jeff? Good. Okay, let's keep going. Oh, speaking of traumatic brain injury, let's talk about that next. Some terms that you want to know. You've probably heard of these terms, like, and this pronunciation of this word is coup. Okay. Now, depending on whether you're in the US or like in the UK, some people will say counter coup, or others will say contra coup, but it's coup and contra coup. So some terms I want you to know are coup, contra coup, and rotational injury. Let's talk about what they actually mean. Okay, so this is probably the best way I can draw it out for you. No matter what, now I don't want you to think this always means the front of the head versus the back of the head. Okay, like in a car accident, let's say where the car is going forward and they slam on brakes. I mean, yes, you're talking about a front to back kind of situation. So you have coup, contra coup going front to back. But let's say you get hit from the side. Now you have coup, contra coup going from the sides. So the way I want you to think of it is you have some kind of impact. On the side of the head that received the impact, that's where you have your coup injury. And then on the opposite side to the impact, so if this is your impact, the side opposite that is your contra coup injury. Okay? Because remember, the head is kind of bathed in all this cerebral spinal fluid. So the brain can shift, it can kind of oscillate as it kind of like a shock wave travels through the cranial vault. A shock wave sends a signal or like a shock and can cause the brain to shift. So what I want you to know is wherever the impact is, on that same side of the impact, that's where your coup injury happens. And then the opposite side to the impact, that's where your contra coup happens. So what you want to know is both of these can happen. You got to, okay, Zach says he's got to run. No problem, Zach, just catching in the replay. So what I'm saying is you want to look for both of these, or you want to anticipate both of these, okay? And both of these are likely to happen. So even though like one side is where the injury is, don't negate looking at the opposite side or palpating the opposite side, okay? You want to definitely look at the opposite side. You also want to feel the opposite side, but you also want to think about, okay, what structures are in there and what do those structures control? Because if I got hit, let's say this is the right side of the head. Well, the opposite is the left side of the head. Well, that could be Broca's area that gets affected. Now their speech could be affected. Or it could be maybe the temporal lobe. It could be the parietal lobe. Okay, so if we're talking left and right, we're talking things like temporal lobe, parietal lobe. If this is front to back, we're talking things like frontal lobe, occipital lobe, cerebellum. Okay, long story short, you want to just kind of know impact. That side is the coup injury. The opposite side is contra coup. You can have both. You're likely to have both. Another type of injury is what's called a rotational injury. And this is where, like especially in the spinal cord, there's some kind of, the spinal cord like twist, okay? And this can cause a rotational injury where the axon, that long section, this axon right here, it kind of gets twisted, okay? Now you have a rotational injury. So terms you want to know, coup, contra coup, rotational injury. All right, that's about all I got to say on that part. Let's keep going. Now, some other types of brain injuries, other traumatic brain injuries. You've probably heard of this, especially like in sports and stuff like that. Football is American football is a big source of concussions and traumatic brain injuries. This is why players have to wear helmets because these concussions can be very serious. Now, what is a concussion? A concussion is where you have a functional brain disturbance. So the brain receives some kind of impact and it causes some kind of problem. So whatever that portion of the brain controls, it doesn't work or it doesn't work well. That's a concussion, but the symptoms typically are short-lived symptoms or signs. By the way, what's the difference in a sign and a symptom? A symptom is what the patient says. A sign is what you observe, okay? So symptom is what the patient says. Sign is what you observe. Tyrese, did you have a question? I saw your hand go up. No, okay. He just said amen. All right, so let's keep going. So the way I want you to think of it is a concussion is where like the brain, like there was some kind of shake to the brain. So the brain got like shook up essentially. That's a concussion. There's another term you want to know, and that's a contusion. So generally when we think, you know how like you learn decap BTLS or decap BLS tick? A contusion is just a bruise. So when you have like a bruise to the brain, so you got some kind of bleeding in the brain that causes a bruise, that's a contusion. Oh, by the way, let's talk about some terms you want to know. So let's just call this the brain, okay? Let's say this whole brain here, all this brain tissue, what is the term for the tissue of the brain? What's that term called? The actual brain tissue that's just normally there. What's the term for all the brain tissue compared to the damaged tissue? Okay, all the brain tissue, the term for that is parenchyma. Okay, the parenchyma is all the brain tissue. However, this red part here is the damaged area. That's called the penumbra. Okay, so sometimes you'll hear like a neurologist, let's say you bring in a stroke patient and they say, okay, I see some damage. We've got some penumbral damage. That's the part, penumbra is specifically the word for the damaged area. But if you're talking all the brain tissue, that's called parenchyma. Okay, just some terms to know, parenchyma, penumbra. All right, so let's go over that again. Concussion is where there's a shake to the brain. A contusion is where there's a bruise to the brain, but you can also have, oh, okay, Becca, I like that. Hey, Becca, how about you just say it? Tell us what you just typed in the chat for me. Say it for everybody.
I remember the difference with a soda can. When I shake it up, that is a concussion. When I drop it, that's a contusion because it dents the can.
Okay, I like it. Okay, so when you shake the soda can, you concuss the soda can. And when you drop the soda can, you contuse it. So you have a contusion. All right, cool. That makes sense. I like it. I'm stealing it, and I'm not giving you credit for it. No, I'll give you credit the first time. After then, it's mine. Now, let's talk about
That's
another
fine,
type
because
of traumatic.
I constantly use your drawings.
Say it again.
I said that's fine because I constantly use your drawings.
Yeah, I noticed that in your video. No, but I love it. In fact, that's exactly what I want you to do. Now, let's talk about this other type of traumatic brain injury, and that's a DAI. Not to confuse that with DEI. But DAI is diffuse axonal injury. What is that? That's where this axon, this long section here, it got stretched or twisted or something like that. It causes some kind of injury, but it's specifically to the axon portion. So that's a diffuse axonal injury. So typically it's like some kind of stretching force. Okay? Those are just some terms you want to know. Concussion, that's where there's a shake to the brain. Contusion, that's where there's a bruise to the brain. It's going to have a damaged area. That damaged area is called a penumbra. And then we also talked about a diffuse axonal injury, and that's where you have some kind of damage to the axon, like due to some kind of stretching force or rotational force. All right, now, everybody good there? We're going to switch over to intracranial hemorrhage. This is a big topic. This is a heavily tested topic on every kind of exam, whether you're talking EMS, so that's EMT, advanced EMT, paramedic, whether you're talking nursing, whether you're talking USMLE steps 1, 2, 3 for medical students and physicians. It's on everybody's exams. PA, nurse practitioner, everybody in medicine gets tested on this. And that's these brain bleeds, so intracranial hemorrhages. There are 4 main types. Like 4 main categories, 4 big categories you want to know, okay? Let's get into them. One of them is called an epidural bleed. Another is a subdural bleed. We also have a subarachnoid bleed and then an intracerebral. The word actually tells you where it's located, okay? If you break down the word, let's say epi. Epi means above. Dura is that hard layer, that dural layer. So remember how going way back, we were talking about the meningeal layers. Wait, where is this? Let me find it. I think right there. We were talking about these meningeal layers, and I said that you have, okay, so this part is the skull, and then you have the dura, the dura mater, then you have the arachnoid mater, and then you have the pia mater, okay? If we have something between so above the dura, so if we have bleeding above the dura, that's an epidural bleed. If we have bleeding below the dura, that's a subdural bleed, okay? Everybody good with that? Literally, the word tells you where it is. If we have an arachnoid or subarachnoid bleed, that's kind of in this subarachnoid space. Or we could be bleeding directly in the brain itself, okay? Let's keep going. So we could either have an epidural bleed, we could have a subdural bleed, we could have a subarachnoid bleed. We could have an intracerebral bleed. All right, let's go back to where we were. Look how much we've covered just in today already. Don't be laughing at my pictures now. These pictures are like magic. So let's talk about these 4 different types of bleeds. Let's shrink that down so we can get it all on one page. Oh yeah, I just wrote those same words I just said. I wrote this to remind me to say it, but I said it already. Parenchyma and penumbra. Remember, penumbra is the damaged area. Parenchyma is all the brain tissue. Let's keep going. This first one right here, I want to talk about this one. This is what's called an epidural bleed. So let's label this one. This is an epidural bleed. Okay. Now, in this epidural bleed, it's typically bleeding from an artery. The main artery that gets wiped out here is what's called the middle meningeal artery. The middle meningeal artery is located on the side of the head in the temporal region. Okay. This is why, so baseball players, you notice how like on baseball helmets, there's this little part that covers this section of the head, right? You know how on baseball helmets, like on one side, there's like this hard piece that kind of covers. It's to protect the middle meningeal artery, because before that, baseball players would get hit with a bat or a baseball, and boom, now they've got to bleed. Okay, so big bleed there. So epidural bleed, it's above the dura. It's bleeding from an artery. The big artery that gets wiped out a lot of times is the middle meningeal artery. It could be any of them. This is just probably the most common one to get affected. Middle meningeal artery. Okay. The other thing about an epidural bleed is it has what's called a lens shape. So the bleeding, when you look at it on a CT scan, this is considered a lens shape. The other thing you want to know here is it has what's called a lucid interval. What does that mean in normal people terms? It means 1 minute they seem fine, the next minute they're out of it. Okay, they're kind of going in and out of consciousness. That's called a period of lucidity or lucid interval. That's what you want to know for an epidural bleed. Because it's an artery under higher pressure, they can lose a lot of blood very quickly. So this is literally in a matter of minutes to hours. They can go from from the time of the impact, they could be dead an hour later. Because they can lose so much blood here so quickly. And all that blood, remember, as I keep putting more and more blood, I keep building up pressure here. That pressure sends a shock wave through that cerebrospinal fluid. We eventually push on the brainstem, and now we cause a herniation. We're going to have increased intracranial pressure, stuff like that. Now, is it okay for the patient to sleep? So some people say, hey, you got to stay awake. Well, the reason you want this patient to stay awake is so you can communicate with them to be able to detect changes in their mental status. Okay. Now, sleeping though could actually be very beneficial for the patient in terms of it actually puts them into a parasympathetic state so that their body is not so stressed out. It decreases the demand on the body. But the reason we actually tell people to stay awake is so we can keep communicating with them so that we can quickly detect changes. Does that make sense, everybody? Okay. Now, so that's an epidural bleed. That's what you want to know for that one. The next one here is this is what's called a subdural bleed. Let's change my color there. This is a subdural bleed. So this is beneath or underneath the dura, the duramater. YouTube, Facebook, you still good? I need to know. YouTube, Facebook, you still with me? Because I can't see you. Give me some love on YouTube and Facebook because I'm starting to feel deprived. Okay, let's keep going. Zoom, you guys still with me? All right. Okay, good. Let's talk about a subdural bleed. A subdural bleed is bleeding beneath the dural layer, beneath or underneath the duramater. This is typically bleeding from a vein instead of an artery, and more specifically, we call these the bridging veins. Okay, this is bleeding from the bridging vein. So imagine this network of veins that bridges the gap here. Those are called bridging veins. This is where a subdural bleed happens. Who is the patient who typically gets this? Typically, it's somebody elderly. It can be anybody, but why do elderly patients get this more when they fall? Okay, let's say they're on a blood thinner. Maybe they have AFib or something. They're on some type of anticoagulant, some type of blood thinner. They're on Plavix, they're on Eliquis or something like that. The other thing, so just them being on a blood thinner and they hit their head, they're more likely to bleed. But the other thing is as you age, your brain shrinks. So now you have a lot more space here. Okay, And because you have a lot more space here between the atrophied brain and a healthy brain, there's more space for blood to accumulate. This is why, okay, now a subdural bleed typically bleeds from a bridging vein, typically involves elderly people, but it can happen with anybody. This is typically slower, but just because it's slow doesn't mean it can't be a lot of blood. But this is why your patient falls today and then 2 weeks later they die. Because for 2 weeks, more and more blood filled up this space. It just took a while before they started having a lot of symptoms. So why do you care? Just because, all right, same thing. You notice there's this pattern here. I talked about this with anaphylaxis. I talked about this with car accidents. If you have a fall, you go to the nursing home. Grandma fell out of the bed. Don't just be so quick to just, all right, grandma, vitals look good. Let's put you back in the bed. Go ahead and finish your lunch. Here's your teeth. Don't just be so quick to do that, because remember, he or she could have a subdural bleed from those bridging veins. They can bleed out very slowly over time. So a question that you want to ask is, are you on any kind of blood thinners? But even if they're not on blood thinners, just remember, as you age, the brain shrinks. There's a lot more space. There's a lot more room for blood to accumulate. The best thing to do is go ahead and get them to the hospital. Why? Because as smart as you are, you don't have a CT scanner, okay? You don't have a CT scanner on your ambulance for my EMS professionals. Now, obviously, if you're in the hospital, yes, you have a CT scanner, but they're already in the hospital. But especially for the pre-hospital providers, so whether that's helicopter or flight EMS, or whether you're talking ground EMS, critical care transport, whatever, you want to have a high index of suspicion. You want to go ahead and get these people to preferably a comprehensive stroke center, so that if they do have a bleed, they're at the right place at the right time. So all of these falls, head injuries, you want to try to get this patient quickly to a neurological center, preferably a place that's like a level 1 trauma center. So far we've covered epidural bleeds and we've covered subdural. Let's go over that again. Epidural bleed is bleeding from an artery, bleeds fast. The most common artery is the middle meningeal artery. It's called lens shape. They have this lucid interval. That's the main things you want to know there. Subdural bleed bleeds beneath the dura. It's slower. You're bleeding from a bridging vein. It definitely can happen to the elderly. It can happen to anybody. The shape of this blood on CT is considered crescent shape, kind of like a moon. Okay. I remember when my daughter was like 3 years old, I came home. I had worked a 48-hour shift, and I came home one day, and my daughter, she's actually a theater major. She's in college now. But when she was about 3 years old, she's always been very theatrical, and she's actually in school. You know, she is an actor. She came home and she was telling me about this play. I had just done a 48-hour shift. I didn't get any sleep at all. And my daughter wants to talk to me. So I go take a shower and I come back. I'm sitting down eating breakfast. And she's like, Dad, let me tell you about this play. And let me tell you your part. She's telling me about the characters are like the sun and the moon and the stars and stuff like that. And she says, Dad, you're going to be the crescent. And I'm like, the crescent? What 3-year-old says crescent? Like, she didn't say moon. She told me my part was the crescent. So in a subdural bleed, you have kind of this moon shape or crescent shape bleeding pattern that shows up on the CT. Let's talk about the next one. This next one here, this is a subarachnoid bleed. Okay, so this is going to be your subarachnoid. Okay, arachno meaning like spider, so it has this kind of spider or spider web pattern to it, where the bleeding just kind of travels around the brain. Okay, that's a subarachnoid bleed. This is the one where they describe it as the worst headache of my life. Okay, worst headache of my life. That's typically, or sometimes it's called a thunderclap headache. This is life-threatening emergency. You're losing a lot of blood. You're damaging. You have a lot of pressure putting pressure on the brain. You're damaging a lot of that parenchyma. Can cause herniation. Big thing here: subarachnoid, thunderclap headache, worst headache of my life. And then finally, you have what's called an intracerebral bleed. So remember, the one out here, that's a epidural. The one below the dura is a subdural. The one kind of in this subarachnoid space is subarachnoid. But the one in the brain tissue itself, that's the intracerebral. So this is intracerebral. Okay? So that's bleeding like within the brain tissue. All of these can be bad. Now, Becca, your question was, do migraines have anything to do with the subarachnoid? It's kind of a different headache pattern. So with migraines, we typically think of like photosensitivity, where you have sensitivity to light, nausea. You may have this kind of aura that happens beforehand, kind of like with a seizure. You have your senses are heightened, that kind of thing. That's more of the typical pattern of migraines. However, not everybody has the typical migraine pattern. In a subarachnoid, though, this is like a sudden onset, no warning, comes out of nowhere, the worst headache like of your life kind of thing. That's how I want you to think of it. Okay. Now let's keep going. Let's see, how are we doing on time? Okay, we got about 20 something minutes, and okay, we got to pick up the pace a little. So let's go. Let's talk about skull fractures. First of all, any questions so far? So any of you on Zoom, Facebook, YouTube? Okay, so Becca says, what's the common mechanism of injury for the subarachnoid and in any ages? Trauma is a big, okay, Jeff asked this, no problem. So trauma is a big cause. High blood pressure, chronic hypertension that's poorly controlled. So you have your blood pressure is very high. Your blood pressure go into your brain is also high. Eventually, you could have an aneurysm in one of those cerebral arteries, and then due to that high pressure over time, it just burst, and then now that causes major intracerebral hemorrhaging. Does that answer that question? Okay, intracranial can be the same thing. So this would be like a hemorrhagic stroke, same kind of thing. Poorly controlled hypertension, so high blood pressure for a long time absolutely predisposes you. So this is why we say your risk factor for stroke goes way up with high blood pressure. It's because when your blood pressure is that high, the blood vessels are under high pressure for a long time. Eventually, it thins out the endothelial layer of the blood vessel. And then when it gets thin, it can't hold the pressure. It just ruptures. Okay? Did I answer that? Okay, good. Let's go. Skull fractures. Okay, so some terms that you want to know are things like battle sign, hemotympanum, CSF, that stands for cerebral spinal fluid. So you can have CSF rhinorrhea or otorrhea. What's that? So orrhea means excessive flow, like diarrhea is excessive flow out the butt. Or rhinorrhea is excessive flow out of the nose. Otorrhea is excessive flow out of the ears. Okay, so you can have CSF that leaks out of your nose. You can have CSF that leaks out of your ears. Some other terms are like battle sign. So what's that? Battle sign is also called ethmoid ecchymosis. Oh, you don't see what I'm doing? Okay. So this is where, mastoid ecchymosis. So this is where you have kind of bruising behind the mastoid process. So behind the ear, that bone back here, that's the mastoid bone. You can have bruising there. That's going to be called battle sign. Okay. Because remember, there's cerebrospinal fluid that's floating around through here. So if I damage anything, I can now have a hole for cerebrospinal fluid to leak. So it can leak out the nose, that's CSF rhinorrhea. It can leak out the ear, that's CSF otorrhea. This is your battle sign or mastoid ecchymosis. You can also have raccoon sign, okay, or also known as periorbital. Peri meaning around, orbit is the orbit. So periorbital ecchymosis or raccoon sign. So these are the big things that you want to know, especially for a basilar skull fracture. Why is it called basilar skull fracture? Because it happens at the base of the skull, okay? So at the base of the skull or basal, you have a basilar skull fracture. Another thing that you can have is this thing called hemotympanum. So this is where, okay, so let's say this is your ear. So let's zoom into this ear. So here's your ear and here's your tympanic membrane. Well, right behind the tympanic membrane, you can have bleeding there. So this bleeding that happens right behind the tympanic membrane, that's hemotympanum. If you have any of those signs, so how are you going to recognize it? Okay. A great way to be able to see it, especially like if you're in a trauma scenario, is you want to take like a sterile gauze, or I mean, just gauze. If it's sterile or not. Yes, the halo test. And what you can do is you can just kind of dip like a plain white gauze, dip it into the fluid. And what you're doing is you're holding it up to the light to see if it kind of spreads out like a halo, if it kind of glows like a halo. That tells you that there's CSF, because sometimes it's just hard to see. So that's why you're doing the whole thing with the gauze, holding it up to the light. See if it kind of spreads out in like this halo pattern. And if we have this positive halo pattern, we'll say, yes, there's probably likely cerebrospinal fluid. Now, it's not like you can do anything about it. If it's leaking, it's leaking. But this is something that you're going to be able to find that says it's probably likely that this patient has a basilar skull fracture. Okay, so there again, we have periorbital ecchymosis. We have battle signs, which is mastoid ecchymosis. We can have hemotympanum. We can have CSF rhinorrhea or CSF otorrhea. Those are just some things that you want to be looking for as you're doing that head-to-toe assessment. These are things that you want to be checking for on all of these major trauma patients or any patient with a suspected head injury or traumatic brain injury. Okay, any questions on that? We good? Okay. Tyrese, are you learning so far? Just come off mute for just a moment.
Yes, sir.
How's this so far?
It's been pretty good. I
Okay.
kind of work in a
Say it again.
stroke. I was gonna say I work in a comprehensive stroke center, so like you going over all the neuro things is kind of like replaying a lot of stuff in my head.
Nice. Okay. And yes, I know, guys, this is a lot of stuff that we're covering. The reason I'm doing this is so it's all kind of in one video. By the way, this video will go up on YouTube, and later, probably today or tomorrow, we'll actually go back in and the team will put in the chapters so that you'll be able to easily go back to a specific section. All right, let's keep going. So now let's talk about this increased intracranial pressure, this rising ICP and herniation and Cushing's reflex or Cushing's response. Okay. Now, some things that, okay, as this ICP gets worse, as you have more and more pressure inside the head, increased intracranial pressure, it can cause things like a headache. Well, you got pressure pushing on stuff in the brain. Yes, you can have now blood vessels dilating in the brain. Now you can have more vasodilation that can lead to a headache. You could have vomiting. Now, how does the vomiting happen? Why does vomiting happen in a head injury? Well, let's talk about it. In your brain, between your brain and your brain stem, you have several sections of the brain where vomiting is affected. So one, like way up here, you have this higher cortical center that can cause the release of certain neurotransmitters that can induce vomiting. In your brain stem, so you have like this section here, your chemoreceptor trigger zone. This is a place where this can now induce vomiting. This could stimulate vomiting. You have a vomiting center. So this portion is called your area postrema. That's where your vomiting center is located. You also have this other part kind of in the back of the medulla, the dorsal part of the medulla called the NTS, the nucleus tractus solitarius. This is also the part that's involved in regulating baroreceptors and regulating blood pressure. Long story short, is there are a lot of different neurotransmitters that get released from these different portions of the brain, things like acetylcholine, dopamine, 5-HT3 or serotonin, histamine. This is why we give certain medications to counteract it. So for instance, let's say we have a whole lot of 5-HT or serotonin. We can use a serotonin receptor antagonist like ondansetron or Zofran to stop the nausea. Okay. Now this happens more, the Zofran is primarily more for when it's like GI related as opposed to head injury related, but you could use both. I mean, you could use it for both. But for instance, histamine also gets released that can cause nausea. So this is why sometimes, or especially years ago before Zofran was so popular, this is why things like diphenhydramine or Benadryl were also used for nausea, because it actually can block this H1 effect, okay, this histaminic 1 receptor. Now, this is probably the more important part I want to talk about. This is an equation to know. This equation is CPP equals MAP minus ICP. Let's break this down. CPP stands for cerebral perfusion pressure. That's the pressure that is taken to send blood to the brain. That's called cerebral perfusion pressure. You know, like when somebody's in cardiac arrest and we're pumping on the chest, we're trying to maintain two pressures. One of them is the CPP, the cerebral perfusion pressure to send enough blood to the brain. The other is the coronary perfusion pressure to make sure we have enough pressure for blood to flow through the heart. This one I'm talking about is the brain one, cerebral perfusion pressure. And so the equation is CPP equals your MAP, your mean arterial pressure, minus your ICP. The reason I want to talk about this is this explains, well, let's go ahead and jump to Cushing's reflex or Cushing's triad. What are the three things that make up Cushing's triad? Type it in the chat. Type it in the chat. What are the three things? We already talked about it earlier when we were talking about the scenario. Okay, heart rate, is that up or down? Okay, okay, Thomas, I like that. So we have bradycardia. What else? Hyper what? Are you saying hypertension? If so, that's right. That's hypertension. And then what else? Irregular respirations. In fact, the way I normally write this is bradycardia, since it's low, I put that on the bottom. Hypertension, since it's high, I put that on the side over here. Let me do it the way I normally do this. So this is hypertension. And then here, this is irregular respirations. Your irregular respirations, which is a ventilation problem. Remember, all problems are either oxygenation, ventilation, or perfusion. In Cushing's reflex, we actually have multiple problems. Like your bradycardia, that's a perfusion problem. Your irregular respirations, that's a ventilation problem. But also, if you're not breathing well, you're not going to breathe air in. So now you also have an oxygenation problem. So you literally have all the problems at the same time. Okay, but the main one that's going to kill them is this irregular respirations, which is a ventilation problem. Let's keep going. Why do you have hypertension, though? Somebody want to take a stab at it? Let's go. Thomas, you want to, can I bring you in?
Sure.
Man, I need a little more enthusiasm than that. All right, so why do you have hypertension in Cushing's reflex?
The brain's trying to push more blood through.
Say it again.
The brain itself to perfuse. Saying your body's trying to push more blood through the brain to get perfusion going through the brain.
Okay, so let's
kind of
start
like overcome that pressure.
I mean, you're on the right track. That's great, actually. But let's kind of start at what's the starting point. So you have some kind of injury, right? Let's say you got hit in the head or you got some kind of injury to the skull. Now we've got maybe more bleeding in the head. So what's going to do to the pressure inside this closed container if I bleed more in there? What happens to the pressure?
It's going to
It's
going to increase.
We have an increased intracranial pressure. Make sense? Okay. Now, but how do I get from increased intracranial pressure to increased blood pressure? So as I have more pressure in the skull, that starts pressing on blood vessels in the brain. If I press on those blood vessels from all that pressure, what does that do to the blood flow in the brain if I push on the blood vessels?
It's going to constrict it.
Yeah. Do I have more blood flow or less blood flow if I push off the
less?
Huh?
You have less, right?
Yes. So I have less blood flow in the brain. That's decreased perfusion to the brain. So what your body says is, wait a minute. Hey, brain, mayday, mayday, mayday. Brain is suffering. So now what happens is the rest of your body constricts. So those other blood vessels significantly squeeze, cause massive vasoconstriction in the other blood vessels. That causes an increase in the systemic vascular resistance And then now that jacks up your blood pressure overall. So it's a compensation or compensatory mechanism to maintain blood flow to the head. Does that make sense? Yeah or no?
This is all from the Monroe-Kelly doctrine, like where there's an extra mass, the brain will kind of
Wait,
compensate
say it again.
for it. Saying, is that basically the Monroe-Kelly doctrine when like there's extra mass in the brain, it'll do that to kind of compensate?
Absolutely.
For
It's
that pressure?
yeah, so extra volume. Yeah. Well, obviously that volume carries weight. So
Volume,
yes, extra
okay.
mass, but extra volume that leads to extra pressure. Yes. All right. So in fact, let's talk about it. In fact, let's use this equation here. So watch this. Let's say your mean arterial pressure is 90. Okay. That would be kind of a normal, that would be a good mean arterial pressure. Okay. But let's say your intracranial pressure is 15. But as you keep bleeding in your head, this pressure goes up. So let's say this pressure now goes to 40. Okay? Well, remember, if the map stayed the same, if the blood pressure stayed the same, because first I have 90 minus 15 equals 75. So my cerebral perfusion pressure would be 75. But let's say if the blood pressure stayed the same and the pressure in the head went up, now I have 90 minus 40 equals 50. So I have less pressure perfusing the brain. So the only way to get this pressure to go up, when this number goes up, this number also has to go up. That's why your blood pressure has to rise. It has to compensate for this number going up so that this number can stay the same. Does that make sense?
Yeah.
Okay. So this sometimes it helps just to kind of see the equation to explain the physiology. So that's Cushing's reflex. Now, that's the hypertension part. How do you get the irregular respirations in Cushing's reflex? Thomas, you can stay with me. How do you get the irregular respirations part?
It'd be the pressure in the back of the occipital lobe, like from the pressure building up on.
Okay, so let's say we have pressure here in the brain. All that pressure starts to build. Oh, now the pressure is pushing down the brainstem. And now, especially in the pons and the medulla, this is where our respiratory center is. So this is the part of the brainstem that controls you being able to breathe. If you put pressure on that, now you're not going to breathe as well. So you're going to have irregular respiratory patterns like Cheyne-Stokes, Biot's, apneustic, ataxic, things like that. All those different irregular patterns, you could have any of those. How do you end up with the bradycardia?
It's a reflex action from the baroreceptors.
Okay, so now here's what happens. So when your body starts raising your blood pressure, yes, it does activate the baroreceptor reflex, and the baroreceptor says, "Ooh," because the purpose of the baroreceptor reflex is to bring down your blood pressure. I'm sorry, no, to bring it back up. In this case, your body says, "Hey, blood pressure's already high. We don't need to bring it up any higher. So let's go ahead and activate. Let's send a signal along cranial nerve number 9, glossopharyngeal. Send a signal along vagus nerve, cranial nerve number 10, into the medulla, right here, into this section right here, the nucleus tractus solitarius, activates the parasympathetic nervous system, sends a signal along the vagus nerve to innervate the heart, tell the SA node to slow down. Thus, we have a slow heart rate. So this is just a reflex from the baroreceptors saying, hey, blood pressure is already high. We do not need to bring it up any higher. Let's go ahead and activate the parasympathetic nervous system, slow down the heart rate. So this is just a reflex that happens. Okay, so now we've talked about Cushing's reflex and the three things that make up Cushing's triad: hypertension, irregular respirations, bradycardia. The thing that's going to kill the patient the most or the fastest is this irregular respirations. Okay, questions on that? All right, I got a few more things I want to talk about because I definitely want to get to spinal cord injuries. We may go about 15 minutes over if that's okay with you. Are you guys still good or let me know. Okay, let's keep going. So now let's talk about what can happen, some other signs that you can recognize when somebody's having a head injury or a traumatic brain injury. And that's going to be some kind of posturing. This is where their body position kind of changes, okay? Both of these are bad. One is just worse. But any posturing is not good. So our two types of posturing we want to know, our terms are decorticate and decerebrate. Okay? Decorticate, decerebrate. Decorticate is where you're bringing your arms toward the core. That's the way I remember that. Decorticate is bringing your arms toward the core. Decerebrate, notice how in decerebrate, the word decerebrate has all these letter E's in it because you have a whole lot of extension. Okay? So this is where you're going to extend. You're going to kind of extend the arms and kind of inwardly rotate the hands. So the arms are kind of extended and inwardly rotated. The legs are also extended. Now, what you want to know is the legs are extended in both situations. But in decorticate, the arms come toward the core, and decerebrate, the arms are extended out. Now, which is which? So what's happening to cause each one of these? Well, what's happening is we have some kind of pressure that's pushing on the brainstem. In decorticate, it's more kind of at the level of like this space between what's called the diencephalon and the midbrain. So it's kind of in this area, but these are not exact like things because this pressure is not pushing on like one specific spot. It's pushing on a whole area at the same time. But generally speaking, we're going to say decorticate happens when like there's pressure pushing on the area between the diencephalon and the midbrain. And then decerebrate is where it's lower down, probably at the level of the midbrain or lower. Okay? But when you see one or the other, it's not necessarily just one specific location. Remember, pressure travels in all directions. Does that make sense? But the reason decerebrate is worse is it's lower down the brainstem. Okay? So it's closer to more autonomic nuclei that control a lot of different things like breathing, heart rate, GI, pupils, stuff like that. Okay? Main thing I want you to know is decorticate is where their arms come to the core. Decerebrate is where their arms are extended. In both cases, the legs are extended. Now, how does this factor into the GCS, the Glasgow Coma Scale score? You know how the Glasgow Coma Scale score has 3 main columns, right? We've got the 3 main divisions. We have eyes, verbal, motor. The Glasgow Coma Scale score, what's the highest number? What's the highest number on a, okay, highest number is a 15. What's the lowest number? 3. Okay, so a GCS can go from 3 to 15. Under eyes, so look at me, I have 4 eyes. So the highest under eyes is 4, then 3, 2, 1. There is no 0. The lowest number on a GCS in any category is a 1. Under verbal, we have 5, 4, 3, 2, 1. Under motor, we have 6, 5, 4, 3, 2, 1. Okay? What I want you to know is this decorticate posturing correlates with the motor of 3. So a motor of 3 is decorticate. And then a motor of 2 is decerebrate. Okay? If they have no movement whatsoever, that's a 1. Like if they don't speak, that's a 1. If they're unresponsive, that's a 1. So if they're in cardiac arrest or completely unresponsive, they probably have a 3. But if they have decerebrate posturing, they're going to go probably to a 2 here, and then whatever else they have. If they're in decorticate posturing, they'll have a 3 here, and then whatever else they have. You'll add them all up to get your GCS. The reason I bring this up is in all cases of altered mental status, you want to assess your GCS. But you really should assess a GCS on every patient. It's just that if they're perfectly normal or physiologically normal at least, their GCS is probably going to be 15, but you should be checking a GCS on every single patient. Just like when do you check breath sounds? On every patient with lungs. When do you check a heartbeat or a pulse? On every patient with a heart. When do you check on a GCS? On every patient with heart and lungs. Okay, so you should really assess a GCS on every patient, and you should assess a pulse and breathing on every patient. To not do that would be wrong. Don't be that person. Let's keep going. Any questions on that? All right, so we've covered posturing. Now, when you're doing all right, I'm going to speed through this part because this is just kind of some basic stuff, but then I want to get to the spinal cord injuries. When you're doing your neurological assessment, you know how so I teach the 5 buckets, right? So bucket number 1 is all about your safety. That's your BSI, scene safety, mechanism of injury, nature of illness, number of patient, need for additional resources, right? And then bucket number 2 is your primary assessment. That's where you're going to start off with C-spine, general impression, where we figure out the age, sex. Then chief complaint, apparent life threats. But then we do A, B, C, D, E, and then transport determination. Okay? But your A, B, C, D, your D is for disability. This is where you definitely want to be assessing a GCS. So any patient with altered mental status, here's what I want you to know, that when you're doing your primary assessment, now, yes, these 2 things are like vitals, so they really come up in bucket number 3, but multiple things can happen at the same time. So while you're doing the primary assessment, your partner or whoever can be getting some vitals and that kind of thing. 2 vitals that we definitely want to check with every single patient with altered mental status is your oxyhemoglobin saturation, so your pulse ox, as well as your blood glucose. In addition to checking those 2 things, though, we also want to check a GCS. So every patient with altered mental status, what 3 things are we going to check? SpO2, blood glucose level, GCS. Okay? Okay, cool. Now, we already talked about preventing secondary brain injuries. Remember that they have the primary injury close to the impact, but then they also have this secondary injury that can happen later. We listed off a whole bunch of things here. The big thing that you want to remember in traumatic brain injuries is you need to do everything possible. That's why you want to fully assess your patient, but you want to do everything possible to prevent the secondary injuries from happening, because these are the things that would kill the patient, like hypoxia, respiratory depression, respiratory failure, the hypotension that could lead to shock, seizures, papilledema, things like that. Now, I'm going to quickly go through this. When it comes to the vertebral column, just in the interest of time, most of you know this. We have, so here's like your spinal cord. Notice that your spinal cord kind of has this cone shape at the bottom. That's called the conus medullaris. Now, what's significant about here is there's this cluster of nerves that kind of are in like a shape of a cat tail or whatever, but this is called the cauda equina. So one thing to know is, let's say you have a spinal cord injury. If this portion of these nerves gets affected, it can now cause cauda equina syndrome. These nerves, especially, these are the nerve roots for like L5, S1, 2, 3, 4, 5, those kind of nerves. They control things like bladder function, a lot of reproductive functions. The nerve roots are going through here. So cauda equina syndrome is where they can have like numbness or paresthesia in like the rectal or anal region. They can have loss of bladder function, loss of bowel control, stuff like that. So you definitely want to know cauda equina syndrome. This is where you have compression of these nerves at the very tip of the spinal cord in this area called the conus medullaris. It's kind of this cone shape. We have 33 vertebrae. We have 33 vertebrae going down the spinal column. Remember, when it comes to the cervical vertebrae, we have 7. We have 7 cervical vertebrae. We have 12 thoracic vertebrae, 5 lumbar, and then the sacral area, it's like this fusion of where S1 and S5 are kind of lumped together. And then finally, we have the tailbone, the coccyx, or the coccygeal region. Okay, what you want to know is, think about this. When you're going to eat, you have breakfast at 7, lunch at 12, dinner at 5. So the order is we have 7, 12, 5, 5, 4. When you add that up, that's a total of 33 thoracic vertebrae. Here's what I want you to know. Typically, there's a nerve that comes underneath every one of these vertebra. Okay? So every one of these, there's a nerve that goes underneath. However, in the cervical one, there's actually one that goes above C1. So the cervical vertebrae, there are actually 8 nerves that go through here. And then for the rest of them, there's 12, there's 5, 5, and so forth. Just the exception is for the cervical spine, even though you have 7 vertebrae, you have 8 spinal nerves. Okay, so I think I wrote that. Yeah, there are 8 cervical spinal nerves, but there are only 7 cervical vertebrae. All right, that's about all I want to talk to you about that. I mean, most of you know this part. Hold on. Oh, nice. Okay, so we have so Jeff gave us mnemonic for oh, nice. Okay, Jeff gave us some mnemonics for memorizing the Glasgow Coma scale. Maybe I can actually, for those of you on Zoom, you see that in the chat, but he gave us ESPN. Then he gave us, okay, I never heard of this one, OC-WIN for verbal, and then Old Ben for motor. Whatever you use, I like that one. However you need to memorize it. Now, I want to go into this spinal cord, and we should be done in just a few minutes. I apologize for running a little over. We were actually supposed to end 5 minutes ago, but this was an ambitious topic to cover like in one session, but we're all actually at the very end. We're close to the end. I want to talk about the spinal cord and talk about some of the spinal cord injuries that you definitely want to know. So the spinal cord carries information. Remember, things go up the spinal, or things go down the spinal cord, and information goes up the spinal cord. What is it called? What kind of nerve travels, or along what kind of nerve does the message go up? I'm trying to ask it without giving away the answer. So we have, that's called an afferent, also called sensory. So the nerve fiber where the signal goes up from the spinal cord toward the brain, that's the sensory nerve or the afferent nerve. And what's the one where it goes down from the brain down to the spinal cord? What's that called? That's called efferent, or also called the motor. So what you want to remember is the sensory signal goes up, the motor goes down. Other terms that mean the same thing would be this. What is called the this is called the afferent. This is called the efferent. Okay, so let's just write that in. This one is, the blue one is afferent. The red one is efferent. Okay. Now let's talk about the spinal cord itself. Let's orient ourselves to the spinal cord. So this portion here, this is the front of the spinal cord. So this is toward the person's front of their body, the anterior portion. This in the back, this is the back or the posterior part of the spinal cord. And then we have the sides. Okay, then we have the center. Now, this part kind of on the outside, that is white matter. This part on the inside, this kind of butterfly-shaped thing, where else do we have another butterfly-shaped organ? That's going to be the thyroid, okay? But this butterfly-shaped thing in the spinal cord, that's the gray matter, okay? Now, some terms to know. So this part out here, this is the white matter. This butterfly-shaped part is the gray matter. Some other kind of sections. So like right here, what I'm drawing right here, this is what's called the spinothalamic tract. So this little section I'm drawing right here, this is called the spinothalamic tract. So let's write that in. Here, let's put this in here. Let's actually do it in red. This little section right here in the anterior part, this is where the spinothalamic, let's break that down. This is where the signal goes up from the spine to the thalamus in the brain. This is the tract, or the set of nerves or the nerve fibers that carry the sense called pain and temperature. So when somebody can't feel pain or they can't recognize temperature like hot and cold, that's where the spinothalamic tract has been affected. Now let's go into, let's go to another tract right over here and over here. This is what's called the corticobulbar or corticomotor. This is the part that actually specifically allows you to move. So the signal that allows, so this is like a sensory nerve. This is a motor nerve that actually physically allows you to be able to move. Okay. Now, this little nerve root over here in the front, this part right here and this part right here, that's called the ventral root. Ventral meaning toward the front. We also have what's called a dorsal root. Dorsal means toward the back. So we have a nerve root that goes toward the back of the spinal cord, and then we have a nerve root that goes to the front of the spinal cord. The one in the front is the ventral root. The one in the back is the dorsal root. There's this other section back here called this little section that I'm highlighting now. This is what's called the, let's put this in green. This is called the dorsal column medial lemniscus. I don't expect you to know the name, especially at the EMS level. For those of you at the medical student level, absolutely. But this is what's called the dorsal column medial lemniscus. It's in the back of the spinal cord, and what gets the message that travels along that portion of the spinal cord is the senses of vibration. So this is going to, back here, this is going to be vibration. Also what's called proprioception. Proprioception, what does that mean? That's like, okay, how do you test for this? You ever seen somebody, maybe you've seen a doctor, patient had a spinal injury or some kind of traumatic brain injury. They ask him to close their eyes, and then they put their hand on their toe, and they move their toe, the big toe up or down, and they say, am I pulling your toe up or down? You being able to recognize which way your body parts are moving in space, the word for that is proprioception. So you knowing how things are arranged in space, proprioception, that actual sense happens in the in the back of the spinal cord called the dorsal column medial lemniscus. Break it down. Lemniscus is just a word for a long nerve. And the word for a long nerve is called a tract. So this is a tract of nerves. It's a long passageway. That's called lemniscus. Medial means that it's in the middle versus on the sides. If it's on the side, that's called lateral. But because this is in the middle section, it's called medial. Column is because it's a column. It's like a tube. And then dorsal is because it's in the back. Dorsal is a word for back. So when I put all that together, the name of that is actually where it is. It's the dorsal column medial lemniscus. Okay, so we just covered dorsal column medial lemniscus. We covered the gray matter. There's this little section right in here. This is called the anterior commissure. This is how signals travel from one side of the spinal cord to the other side. For instance, the sense right here, the spinothalamic tract. So let's orient ourselves. Let's say this is the patient's left side. When you feel pain on your left side, the signal actually crosses. So this signal goes from here in the ventral horn. It goes through here. It crosses over the anterior commissure, and then it travels up the spine. Okay? So it actually goes to the, so for you, when you feel pain on your left side of your body, that signal is traveled to the right side of your brain. Okay? But the split for that happens at the level of the spinal cord. Now, on the other hand, let's say this one here that controls motor function. Yes, this signal, eventually, it actually just goes up the same side of the spinal cord, but then once it gets in the brain, that's where it crosses over. Okay? So when you move your left arm, it's because of the right side of your brain. But the crossover, where it crosses the street, the word for crossover is called decussation. Where it decussates for this tract is in the brain, but where it decussates or crosses over for this tract is actually in the spinal cord itself. That's all you need to know for that. Like, I could spend a day on this one slide. No joke, I could spend about 8 hours on this. But some of you are like, whoa, what kind of words did he just use? So already we've used corticobulbar or corticospinal tract, spinothalamic tract, dorsal column, medial lemniscus. Now, let's talk about what this all means. Let's say we damage your spinal cord. There's this thing called dermatomes, and what this is this is like an area of skin that's controlled by a certain nerve. Okay? So like, for instance, C2, cranial nerve number 2, or not, I'm sorry, not cranial nerve, spinal nerve number C2, spinal nerve controls like this part. So it controls like your face. Okay? But like C4 kind of goes in this pattern. I don't expect you to know all of this, but the ones I want you to remember are like the top 8. So the way I remember this is C6, 7, and 8. So this is spinal nerve, C6, C7, and 8. So the way I remember this is we have our thumb, we have our middle finger, and we have our pinky finger. C6 is our thumb, C7 is our middle finger, C8 is our pinky finger. 6, 7, 8. That's C6, 7, 8. So that's our thumb, our middle finger, our pinky finger. Okay? Another prominent dermatome that you want to know is the level of T4. If they can't feel anything around like the nipple line, T4 probably got knocked out. Okay? Now, where's T4? So remember our spinal cord. So T4 is right here. If we knock out the nerves in this part of the spine, it's going to probably affect like sensation around the nipple line. If we knock out like, let's say C6, so there's a nerve, C6, C7, this would be C7 spinal nerve, and then C8 spinal nerve, and then C6 spinal nerve. If we knock out these, let's say we knock out C6 spinal nerve, which is under C5 vertebrae, that's going to knock out your thumb. You can't feel anything in your thumb. If you knock out C7 spinal nerve under C6, that's going to knock out your middle finger. And then, so now you can't move your middle finger or can't feel anything there. And if you knock out C8 spinal nerve, which is under C7, then now you can't move your pinky finger. These are just some quick ones to know. So C6, 7, 8, T4. Another one to know is T10. T10 is at the level of the belly button. So if they can't feel anything around their belly button, they probably knocked out their T10 spinal nerve, which is under T10 spinal nerve, which is under the 10th thoracic vertebrae. L4, this is the medial part of the ankle. So L4, so, you know, we have a lateral. Lateral is on the side, and then on the insides, that's the medial. So the medial malleolus, that bone on the inside of your ankle, if you can't feel anything around that area, that's probably that L4 got knocked out. L5, this is your big toe. This is another one. So it's not like you need to check every single dermatome, but these are some big things to check. Quickly have them move their thumb, their middle finger, their little finger. That tells you your cervical spinal nerves. Do you feel anything around your nipple line? Do you feel anything around your belly button? Okay. If I stroke the inside of your ankle, do you feel that? Wiggle your big toe. Try to wiggle your little toe, or do you feel me touching your little toe? So this is how we would actually assess those dermatomes. Now, a neurologist or a neurosurgeon, they're going to literally go like level by level, checking every single dermatome. That takes a lot more time. We don't have that kind of time in an emergency setting, but you can knock this out in seconds, right? You can ask this stuff pretty quickly, and it's going to be great information to be able to relay at the hospital to the receiving team. All right, so that's dermatomes, and you can go back over this. Now, I do want to talk about this, some terms that you want to know when it comes to spinal cord injuries. Some big things here, C345, the way I remember this is C345 keeps the diaphragm alive. So if you have a high cervical injury, it's probably going to knock out your diaphragm. When you knock out your diaphragm, now the patient can't breathe. Okay? So very high spinal cord injuries are often a lot more fatal just because of the things they knock out. Now, there's a term that you probably have heard of, and that's tetraplegia. Tetra means 4. That means where you can't move 4 of your limbs. So all 4 limbs are paralyzed. Another term that means the same thing is quadriplegia. Quad meaning four, tetra meaning four. So quadriplegia, tetraplegia, both of those are where you're paralyzed in all four of your limbs. I'm sorry, YouTube asked a question. What was that? What would you need to look out for in the field or on a test question? Oh, this was earlier about a type of bleed. Hopefully I answered that. If not, let me know. Now, another term is paraplegia. What's the difference between quadriplegia and paraplegia? Somebody want to take a stab at it? I promise we're almost done. Okay, so be more specific when you say two limbs. Because two limbs can be top versus bottom or left versus right. Okay, so paraplegia, you want to think top versus bottom. So it's typically where the bottom half is not working, but the arms work. So they can't move their legs, but they can move their arms. That would be paraplegia. So if you have a paraplegic, their legs are paralyzed, but the arms still work. But then there's another term that I forgot to put in, and that's hemiplegia. Hemi meaning half. This is where one half of the body works and the other half doesn't. So maybe the left arm and left arm work, but the right arm and right leg don't work. Okay. So half hemiplegia is where you have imagine whoa, what did I just do? All right, let's do that over. Imagine if we chop them in half, these two work and the other two don't work, or vice versa. Okay, then that's called hemiplegia. Now, I want to get into just a few other concepts to know. When it comes to spinal injury, some other terms that you may have heard of. We have a flexion injury. This is where it kind of the spinal cord gets kind of twisted and kind of pushed down like this. That's coming up. I promise. Thomas is coming up. I think it's next, actually. It is. Okay. So this, where the spinal cord gets kind of twisted like this and you have a force that pushes down, the term for that is called flexion. I just want you to know what these terms mean. The other one, this is going to be called extension. This is where the spinal cord gets kind of stretched in it gets stretched upward like that. That's called extension. Then we also have, this would be this one. Oh, I don't have it there, but that's rotation. So this is a rotational injury. This next pattern where it kind of pushes, you have a force that's pushing from the top and the bottom. That's actually called compression. So you may have heard somebody having a compression fraction or fracture of their spinal cord. Compression is where you have a force going from the top and a force going from the bottom that kind of pushes the vertebrae into each other. That's called a compression. This next one here is where things get kind of misaligned, so to speak. This is the best way I could draw this. This is called a distraction force. That's called a distraction force. Now, let's say somebody jumps out of a building or something like that, and they have some kind of vertical force. This is called axial loading. Do I have that in there? Oh yeah, it's right here in front of me. This is called axial loading. And then finally, let's say somebody gets a bullet or a knife or ice pick or something that goes through their spinal cord, then that's going to be called a penetrating injury. Okay, these are just terms to know. Now, all of them can have similar symptoms. This is just the actual medical term for what do you call it when it looks a certain way. Okay, now how are you you're not going to necessarily be able to tell this. We'll need x-rays, we'll need CT scans, or more specifically, maybe an MRI can help with some of this. These are just terms to know: flexion, extension, rotational force, compression, distraction, axial loading, and penetrating. Okay? Now, I want to get to this part. Let's say we have a complete versus an incomplete spinal injury. Okay, what is that? A complete spinal injury is where the spinal cord completely gets damaged all the way across. Okay? So if I have a spinal cord, remember how we had the spinal cord here toward the back? This was the dorsal column medial lemniscus. Then we had the corticospinal. we had the spinothalamic, we had the gray matter in here. If I damage the whole thing, I'm going to damage a whole lot of stuff. Like if I have a complete injury where the whole spinal cord gets wiped out at whatever level, everything below that level is going to be affected. Now, I want to talk about, so there's one called complete. That's where the whole spinal cord gets damaged. Incomplete is only where a portion of the spinal cord gets damaged. And we're going to go over examples of that. Complete is where below that level, so let's say I have a damage right here at the, let's call it, I don't know, here, let's say L5. Okay. That means that below L5, so everything that L5 controls, everything below that is not going to work if they have a complete. So they're not going to feel pain. They're not going to feel temperature. They're not going to feel vibration. They're not going to be able to move. Nothing below that level works if they have, oh, you don't see what I'm doing. Nothing below this level works if they have a complete spinal injury. But let's say they have an incomplete. Now, so your terms are complete, incomplete, and then sometimes you'll have what's called sacral sparing. That means that like the arms and legs don't work, but around their sacral area. So let's say if this location, but in the back, around their sacral area. Do I have a picture of that? It's where I put the dermatomes. That's okay. We'll just keep going. The sacral area, so your butt area, they still feel pain there. They still have sensation around the rectum or around the anal area. They still have bladder control, so they can still like feel their bladder filling up, stuff like that. They still feel the urge to poop, to have a bowel movement. So sacral sparing is where those nerves still work and those functions still work, even though they may not be able to move or they may not be able to feel anything. Now, let's talk about these incomplete syndromes. All right, so let's shrink this down. We're almost there, guys, I promise you. So, incomplete syndrome, some ones you want to know is this one right here, this pattern. This is what's called a, okay. Here are the terms you want to know. We can have a central cord lesion. So that's where the central part of the cord gets affected. We can have an anterior cord. We have a situation called Brown-Séquard. And then we have a posterior cord injury. Let's break them down. A central cord. Let's start with central cord. This is where just the center portion gets knocked out. Okay, in a central cord lesion, the center part gets knocked out. Now, how does this present in a patient? What's the clinical presentation of this pattern? This is where they have motor weakness, because the reason they have motor weakness and not total paralysis is because this cortical tract over here on the side, a portion of it is affected, but not the whole thing. Like if the whole thing got affected over here, then they couldn't move at all. But because a portion of it got affected, they have motor weakness instead of paralysis. So they can move, but it's very difficult to move. Okay. And typically it's where the motor weakness affects the arms more so than the legs. And it's just because there are different parts of the brain and different parts of the spinal cord that controls arms versus legs, for instance. Okay, so motor weakness primarily affecting the arms more so than the leg, but they do have sacral sparing. So the sacral area around the butt, those nerves that control things like bladder, bowel function, those still work. Okay, so they still feel like they got to pee, they still feel like they got to poop, that kind of thing. So that's a central cord lesion. Let's go to the next one. Any questions on that? So this picture here, this is kind of your normal. What I would do is I would draw this out. Remember, we have so here's your spinal cord. Here's your corticospinal tract. Here's your spinothalamic tract. This is your dorsal column medial lemniscus. Remember this part, spinothalamic, controls pain and temperature. Okay, and we'll just say pain. Noxious stimuli is what it's called, but pain and temperature. Let's keep it simple. Corticospinal controls movement. Dorsal column medial lemniscus controls vibration, proprioception, fine touch, or 2-point discrimination. What does that mean? Like if I touch you in 2 places, and you feel like you're touched twice, that's called 2-point discrimination. That also happens right here. Okay? So this is called crude touch, and this is called fine touch. This is normal. You always want to know normal for everything before trying to recognize abnormal. Always start with normal. So we talked about one abnormal situation is where we damage the center of the spinal cord. That's a central cord situation. They have motor weakness. It affects the arms more so than the legs, but the sacrum is okay. Let's go to the next one. Let's say we knock out the front part. This is called an anterior cord lesion. Well, now what are we going to knock out? Well, the spinal thalamic tract runs through here. That controls pain and temperature on both sides. So if we have an anterior cord lesion, they don't feel pain or temperature on the left side or right side of the body. They feel pain or temperature nowhere below that level. So let's say if I'm at L5, everything below L5, they feel no pain and temperature, and they also have no movement below that level because we're going to damage the corticospinal tracts. So here we damage corticospinal, which is movement, and we damage spinal thalamic, which is pain and temperature. So they have no pain, no temperature feeling, and no movement below that level. Does that make sense? Give me a thumbs up if that makes sense. YouTube, Facebook, are you still with me? Okay, now let's go over. So this is an anterior cord lesion, but this part is still okay. So they still have vibration, position sense, proprioception, fine touch. Those senses are still okay. So if you put a tuning fork on their foot, they feel vibration, but they don't feel cold or hot, and they can't move, okay? Because this portion is okay, it's just this portion is knocked out. And what I would do is take some time to just kind of go over this again. You're probably not going to get this your first time. This is when you want to draw it out. You want to kind of talk about it. But I'll provide this so that you can review it. So this is an anterior cord lesion. Now let's go over, what's this one? Okay, this is a posterior cord lesion. This is the back of the spinal cord. Well, what's in the back? Well, in the back, this is the dorsal column medial lemniscus. That's the part that controls proprioception. That's how your body parts are arranged in space. This also controls vibration, light touch, stuff like that. So on both sides of the body, below that level, they don't feel any vibration, position sense, or fine touch, but they can still move, maybe. It depends on whether the corticospinal tract was also involved. They may or may not be able to move, but they should still feel pain and temperature, okay? Because your pain and temperature in the front, those are still okay, so they can still feel pain and temperature on both sides. They may or may not be able to move. It just depends on whether this corticospinal tract got involved. That's a posterior cord lesion. Now, the one that you asked about was Brown-Séquard. Brown-Séquard syndrome is where one side, so either the left side or the right side, gets knocked out. Well, remember, what's in the front? Over here, we've got a spinal thalamic tract that controls pain and temperature. Over here, we've got a corticospinal tract that controls movement. Back here, we've got dorsal column medial lemniscus that controls vibration, proprioception, light touch. So you're going to wipe out a whole lot of things, but it's going to be different on each side because the sense of this spinal thalamic tract, where it switches over, is at the level of the spinal cord. So what that means is, let's say the left side of the spinal cord gets knocked out, because the switch goes to the other side, they don't feel pain and temperature on the right side. So let's say in this situation, they knock out the left side of their spinal cord from the front to the back, from the front, the center, and the back. How it's going to manifest is they're not going to be able to move on the left side below that level, and they're not going to feel like, they're not going to have proprioception, or they're not going to recognize how their body parts are moving below that level on the same side as the injury. But on the opposite side, they're not going to feel pain and temperature. Okay, what you want to know, the big thing you want to know for Brown-Séquard is pain and temperature is affected on the opposite side of the lesion. That's the way you want to know it. Brown-Séquard syndrome is where pain and temperature is affected on the opposite side, but movement and proprioception is affected on the same side. Now, what are the words for those? So since this is the left and these are the left, this is called ipsilateral. Ipsi, same. Lateral, side. Same side is ipsilateral. But when it's the opposite side, that's called contralateral. So let's summarize that. Brown-Séquard is where you have contralateral loss of pain and temperature, ipsilateral loss of movement and proprioception. Does that make sense, Thomas? Thomas, does that make sense? Yeah? Okay. Now, and what I want you to do is go back through this, go back over it again, be able to draw these pictures yourself. And I'm also going to provide my drawings for all of you in the community. Okay, those are your spinal cord injuries. I want to end with this last part here, spinal shock versus neurogenic shock. And what's the difference? This is a real important thing to know, and they're actually not the same. Okay? The way I want you to know it is neurogenic shock is where you have no sympathetic output. Remember how we were talking about you have a nervous system that's a central nervous system and peripheral. Peripheral is divided into autonomic and somatic, but autonomic is divided into sympathetic and parasympathetic. In neurogenic shock, the sympathetic side doesn't work. You have no sympathetic input. In neurogenic shock, the big thing here is where you have lots of vasodilation. This is actually a circulatory problem. This is more of a perfusion problem. Neurogenic shock, where you have all this vasodilation, causes what type of shock? So remember our 4 types of shock. We have cardiogenic, hypovolemic or hemorrhagic. We have distributive, and we have obstructive. Neurogenic shock is what type of shock? Type it in the chat. Oh, okay. Somebody did already. It's distributive. The other types of distributive shock, remember, distributive shock affects your autonomic nervous system, which is exactly what we're just saying here. It affects your autonomic nervous system. Specifically, it affects the sympathetic tone. So the 3 things that affect your autonomic nervous system are anaphylactic, neurogenic, and septic shock. Neurogenic is a circulatory problem where you have massive vasodilation. And now when you have this massive vasodilation, you're also going to have more venous pooling as well. That's going to drop your blood pressure and also drop your heart rate due to a baroreceptor reflex. So the way you want to know this is in neurogenic shock, you're likely going to have a very low blood pressure. However, in spinal shock, which is more associated with Cushing's reflex, especially if it's higher up in the brain, that's going to be a higher blood pressure, or it may even be normal, okay? Neurogenic shock is typically going to be a low blood pressure. Now, because they've got a low blood pressure and they've got all this vasodilation, our treatment there is going to be some kind of vasopressor to squeeze the blood vessels to increase the systemic vascular resistance and make the blood pressure go up. What's that drug going to be for neurogenic shock? Type it in the chat. What drug am I going to use for neurogenic shock? Let's see what you get. Type it in the chat. Okay, this is going to be norepi or Levophed. Okay, so norepinephrine or Levophed is what we're going to use primarily for neurogenic shock. However, for spinal shock, that's more of a spinal nerve problem. It's not a circulation problem. It's not dealing with blood flow. It's more of a nerve impulse problem. And the blood pressure may actually be normal or it may be high. The final thing I wanted to talk about is a situation called autonomic dysreflexia. Anybody ever heard of that term before? Autonomic dysreflexia. Sometimes it shows up on a test question. What is it? Okay, it's where, let's think of it this way. Let's say you have some kind of spinal injury. You got a spinal cord injury, and your body is saying, like, because below that injury, all kinds of things start happening. But what's happening is you still may have some kind of sensory input, or you may not feel it, but your body senses that something's wrong. Some examples would be, or that you're in some type of distress. So imagine somebody with a spinal cord injury and they can't move, or they can't talk or whatever. They can't like move their hands to point to where the problem is. But their body says, hey, I sense that your bladder is getting full. I sense that your colon is getting full and you got a lot of pressure. You need to pee. You need to poop. But their body can't like respond appropriately. What happens is you get kind of a disconnect above the injury versus below the injury. Above the injury, all kinds of reactions are starting to happen, like blood pressure is starting to go up, their temperature is getting hot above the injury, stuff like that. They may have like a sudden rise in their blood pressure, but they're just sitting there and you're like, why is their blood pressure going up? Whenever you see that, so the term for that is autonomic dysreflexia. It's where there's like a disconnect between what's happening above the injury versus below the site of the injury. And they end up with like these sympathetic symptoms, especially above the injury, like high blood pressure. They get hot, tachycardia, stuff like that. So if you touch their body and part of it is hot and part of it is cold, don't just say, this is just some strange thing. No, this is autonomic dysreflexia, where their blood pressure can shoot up so high that it can now cause their brain to herniate. It can cause them to have a stroke. This is actually a very serious thing that you want to recognize very quickly. Once again, autonomic dysreflexia is where you have a disconnect between what's happening above the injury versus below. They have all this sympathetic input where they have a lot of sympathetic type responses above the injury, high blood pressure, tachycardia, fever, stuff like that, hyperthermia. And then they have kind of the opposite effects below that injury. So bradycardia, lower blood pressure, like in the legs, their legs or feet are cold, stuff like that. Okay. And that was it. Okay. Now, I know this was a lot. This was a long session today, but we covered a lot of stuff. Did you learn something today? For those of you, YouTube, Facebook, hey, Tyrese, what'd you learn today, my man? Hold on, let's get you in. Guys, I appreciate you joining me. This was a very important topic to know. Yes, we covered a lot in this one session. Thanks for hanging in there with me. I do encourage you to go back through this. Tyrese, what'd you get out of today, my man?
Definitely the autonomic dysreflexia. I have seen it before. I just didn't know exactly what it was.
Okay.
So you
Okay.
was brown
sequoia. Okay.
I can't never say that. Brown sequoia. I knew the term. I could never like break it down to actually make sense to me.
So remember, brown sequoia is where you're going to have you're going to either affect the left side or the right side. Mm-hmm. But the big thing you want to know is whichever side it's on, they're going to have loss of pain and temperature on the opposite side. So that's loss of contralateral pain and temperature, loss of ipsilateral movement and proprioception. Okay. And go back over this several times. I encourage you to literally just draw it out. Like literally just take a sheet like this or a screen or whatever, draw you a spinal cord and say, okay, what happens if I have a central cord lesion? Well, if that central cord affects, like, remember that you got these two are spinal thalamic. They control pain and temperature. This is corticospinal that controls movement. This is dorsal column medial lemniscus that controls 2-point discrimination, vibration, proprioception, fine touch. So literally just put a lesion in different parts and say, okay, if it's here, what is it going to wipe out? If it's here, what is it going to wipe out? If it's here, what is it going to wipe out? What if it's here? What is it going to wipe out? And so what I would do is just take a picture or take a piece of paper, draw this out, and make sure you know, okay, this is central. Okay, this is anterior. This is posterior. This is brown sequoia. This is brown sequoia. Well, one half or the other. If I knock out the whole thing, that's a complete spinal injury. Okay, so take the time to draw this out. That's how you'll get really good at this. Okay. What else? Any big
Yes, sir.
takeaways today?
Oh, my bad. I didn't know you still with me.
It's all on you, my man. Any other big takeaways?
Yeah, the name of the one pupil bigger than the other.
Anasequoia?
Anasequoia. That was
Okay.
but-
And I highly recommend
and-
that you go back over this entire thing. You know, you can break it up. Obviously, this was a longer session with me just teaching it, but when you play it back, you can kind of do it as you want to do it. Was today's session beneficial though?
Yes, sir.
Okay. And as you continue going through our cohorts together, you're going to learn so much. There is where I'm going to teach you how to break down all the questions. We're literally going to do hundreds of questions in those 3 cohorts together. So welcome aboard. You're in the right place. Welcome home. When is your test?
I have not scheduled it.
Man.
I wanted to do
What attempt number
I
are you
wanted
on?
to
Do
do
you
the-
care to say or no?
number 5.
Okay, all right. So we got to
5.
buckle down. I want you to jump into use the daily tracker. It literally specifies what you do every single day, day 1 through day 21. We've had lots of people pass. We're approaching over 100 this year alone. And we've helped a lot of people at every single level. In fact, the majority of them have been paramedics just because that's where the need is. But welcome aboard. Glad to have you with us, and keep learning with us. We'll be
Thanks,
back
sir.
together tomorrow for another live
Hello.
session. Tomorrow is the weekly accountability session. So that'll happen tomorrow. Look at the calendar. Now, that's not on Zoom. That's not on Facebook and YouTube. That was just something we did today. But for those of you in the community with me, I'll be together with you on Wednesday and Thursday this week. Thursday evening, Wednesday morning. Look at the calendar for details. All right, who else we got? Jeff, what'd you get out of today, my man?
It was all good review. Like I said, I took the test one time, but just really breaking down the TBIs, the epidural, subdural, subarachnoid, just knowing where it affects and what type of injury would cause that. And then the pupil thing, there was a lot of questions that were simple on the test. I just was kind of not necessarily guessing, but taking a stab at
And
it.
sometimes it's just a matter of knowing terminology. Did it help with me doing all these pictures like this?
Yeah, absolutely.
See, most people teach this
the
stuff with just
pictures-
PowerPoint slides, right? But I really do.
Yeah,
These pictures are magical. I highly recommend that you guys go over the pictures. By the way, there was a comment on YouTube saying thank you. I appreciate that. You said you learned a lot, especially about the brain bleeds and how in depth I went into everything. So thank you for that. Jeff, anything else you want to share? I forgot. I got a private coaching session in a few minutes.
Nothing really. I go on shift tomorrow, so I'll try to be on that. But yeah, I'm on day 4 of the cohort, just knocking it out, studying it, doing the rapid drills, hitting the questions, getting really good. Only a few wrong on the on between the 100 questions.
Okay.
Kind of per each day, so I'm feeling pretty good.
When you're getting answers wrong, it's not to beat yourself about getting it wrong. I mean, you either get it right or you're wrong. But understand why every answer is right and understand why every answer is wrong. What that does is it helps you kind of install these patterns. And the more of these patterns that you see, when you're now sitting in front of the real exam, those patterns just like jump off the screen at you. Okay.
Yeah.
So just keep going through. Would you say that you're only in cohort 1? Would you say that you've learned a lot just in cohort 1?
Yeah, I'm in day 4. So I've learned a lot. It breaks everything down. Everybody tries to study all these different apps and questions, but breaking it down into each section and then just re-hitting it. And then the next day you do it, you kind of retouch the first day and then the second day, and it just kind of keeps building. So it's definitely very beneficial.
Okay, good. And so for those of you who don't know what he's talking about, we have something called, especially at the paramedic or advanced EMT level, we have something called the 14 days program, the 14 days to paramedic immersion experience. This is where it's a program where in 2 to 3 weeks, where the goal is for you to be ready to test in under 3 weeks or right around 3 weeks. For those of you who are interested, if you like how I've taught you today, this was just one topic. This was just neurological emergencies. But in our cohort, not only am I teaching you content, I'm really teaching you how to break down these questions. So for those of you who are struggling to pass like the National Registry, the NCLEX, the USMLE, whatever your test is, now obviously the majority of our students are EMS students, so they're taking National Registry. So if you need help passing your EMT level, advanced EMT, or paramedic level, send us a message, get into our program right away so that we can help you. We've helped lots of people, and you'll be able to get access right away, and you can go ahead and start your training. So a little plug for that. Thomas, I also saw your message. You want to talk to me? I'll end the session, and then I'll talk to you so that we stop the recording. But tell me what you got out of today.
Today was a great refresher on the cranial nerves and then going through all the TBI injuries and specifically going through the spinal cord injuries, which I found really interesting the way you just break them down more than what I've read in the textbook.
Okay. Yes. I like, well, obviously I like drawing pictures because that's the only way I know how to teach. I'm not a PowerPoint guy. It actually, like, to physically have to do a PowerPoint, I was like, oh, this is just painful. But it helps for me to just at least stay organized so I know what the topic is to cover next, to make sure I cover it all. Any big takeaways today?
Mainly just the detailed breakdown in the spinal cord injuries. Because again, most of the books I've read, even in like PHTLS, they don't really get too in depth in it, especially like how the nerve pathways work. So understanding that really does help you be able to break down which injury you're.
Now, why do I go into that level of detail? Because sometimes it helps you to, like, the more you know about normal, the easier it is to recognize abnormal, or at least understand abnormal, right? Because imagine if I didn't tell you the pathways, if I didn't talk about spinothalamic or corticospinal or dorsal column medial lemniscus, and I don't show you where those are, I just say you lose this, and you're like, well, how does that happen? Right? But when I draw a picture for you, now you can say, oh, well, I see why I lose pain and temperature because of where it's located. Does that make sense? Or I see why I lose vibration, proprioception, light touch, 2-point discrimination, because that is from the back, and we knocked out the back in a posterior cord lesion, for instance. Okay? All right. And just hang on. I'll talk to you. I do have to hurry because I've got a private session that starts in 8 minutes. Yeah, but let's see. Who else we got? Steven. I think I talked to you the other day. Steven, how you doing, my man?
Doing good.
I'm not sure when you came in today, but what was this like for you today?
Late. I just came in. I was on calls all day, so I got the chance to
tell them patients you gotta wait. Like, they better wait. We got class in session. Okay, but the part that you did get, how was it?
I'm getting this right now.
Oh, okay. So you missed a lot. A whole lot.
3 minutes.
You definitely want this replay will go back up. Now, it'll be available immediately on YouTube right after this broadcast ends in a few minutes. But it'll be sectioned off and put in chapters later and then uploaded into the school community for you all. That'll happen either today or tomorrow once the team gets done with that. I'll make the announcement and let you know that the video's been uploaded. But if you want to dive into it right away, you can go to the YouTube channel, and then you'll be able to see this right away under the live videos. Definitely go back and watch this video. Would you guys say we covered a whole lot in today's session? Yeah? Okay. So go back and watch this because we covered so much about brain, spinal cord, cranial nerves, traumatic brain injuries. We covered a whole lot in this one session. Okay. Tanija, how you doing? Let's see. Can she come in?
Hi, I'm doing good.
Okay. What'd you get out of today?
Today was pretty interesting. I kind of was like in and out. I was like cooking a little bit, so I had like paused my screen. But it was good. One thing that kind of stood out was I think it was like the fascias, and it was talking about like the G and the the G and the S. I was like, oh, like I always struggle with those two.
Okay.
Or like with that. That was pretty cool.
Wait a minute. You even have a brain shirt on. Check you out.
Oh, stop. Yeah, it's like one of my school shirts.
Okay. Man, I mean, shoot, I don't even have a brain shirt. I gotta get one. Hey, but
Yeah, this is pretty
just
cool.
for everybody else to know, what kind of sandwich you making back there?
Oh, I'm making. I'll show you. I got some eggs and some sausage.
Wow. Okay.
And then
I haven't eaten at
I'm
all.
a
Okay,
little
all right, that's
old
enough of
school.
that because I'm hungry.
Oh, I'm a little old school, so yeah, I be toasting my bread on the stove.
What? Okay. No judgment. All right. Well, thanks for
Well, it
joining
comes
us.
out perfect. Look.
Okay. All
Of
right. So,
course.
guys, anybody else have anything else you want to add? Monica, I see that you're there. Monica is actually one of our newest paramedics who she passed her test. She joined our program, passed on her first attempt in the minimum number of questions just last week, I believe. She joined us while she was in paramedic school and took advantage of the program, locked in with us, and 3 weeks later passed her, or I think it was like 3 weeks later, she passed her paramedic. Monica, you want to say anything? We're going to say that's a no. All right. So, guys, it was a pleasure having you today. I hope you learned something today. What I would encourage you to do now, obviously, I can just sit here and talk for hours, right? But what I want you to do is go back through this video, take the time, draw the pictures with me. I'm going to provide you the worksheets that we use so that you have the images. So you can literally take each part and make sure you understand it. As I often say, when you can teach it and draw a picture, that's when you really understand it. That's going to help you on a test. That's also going to help you instill confidence in your patients. Because when you can talk to your patient and explain to them, teach them in real time what's going on, and you say, hey, ain't nobody got time to be teaching patients, you don't? I've been in the field probably longer than most of you, and I've taught a whole lot of patients in the back of an ambulance or in the back of a helicopter. So, or in an emergency room or in a classroom or wherever. I've taught a lot of people. What I'm saying is you definitely want to take the time to be educating your patients. Now, yes, sometimes the situation is so critical that you don't have time to be explaining things. But even, let's say you have a cardiac arrest or something and the family member is there. If you're not the one that's actively involved in patient care, so let's say you're the ALS provider that's the team leader, you should still take the time. If all the tasks are happening, you should still take the time to explain to the bystander what's actually going on. What are you doing to their loved ones? That's going to instill more confidence in them. They're going to trust you more. And now, especially if you have a patient who's conscious, when they trust you more, it actually helps them get better because they're not as stressed out. They don't have as much sympathetic activation. They can calm down more. They can get into more of a relaxed or more of a parasympathetic state. You're going to ultimately have much better clinical outcomes. So long story short, make sure you're educating your patients. We don't have time for any more questions tonight or today. I got to go to my next session, but it's been a pleasure with everybody. And I will see those of you in the community bright and early tomorrow or same time tomorrow. See you then. Good day, everybody.